I'm too short. Okay. Okay, good afternoon, ladies and gentlemen. Welcome. I'm Elizabeth Tamang. I'm the coordinator of this Young50 project, and I'm really glad to have our final event here in Brussels. And so for our first welcome address, we actually have Annalisa Bisson. She's the Director of International Relationships of the Veneto region in Italy, and she also has an office based here. And after her, we have Yvette Azzopardi, who is our policy officer, and she'll be connected via digitally because she could not be here in presence. But we are really very glad to have all of you here also in presence. We also have a lot of people who are connected, and we are really happy to have this final event and also to share not so much the results, but lessons that we have learned and also what has happened in our partner countries. So a really good welcome. Thank you, Annalisa.
Thank you, Elizabeth. Good afternoon to everybody. And on behalf of Veneto region, I am really honored to take part to this conference, which is the final event of Young50 project. I would like also to thank ProMIS for this invitation, and let me congratulate Veneto Region's local health authority number 6, who is Euganea, the coordinating partner of the project. Both of you have done a great job and achieved important results. The aging process in the countries of the European Union is a phenomenon that has significant social and economic consequences, as well as physical policy repercussions on responsiveness of current public welfare system. Indeed, it's becoming a central theme of European, national, and regional political agendas. This is particularly true for Italy, where life expectancy at birth is almost 83 years. Furthermore, Italy has the highest share of 65 plus in the entire European Union, 23% of the total population, while 37% are above 50. For this reason, active and healthy aging is today a pivotal theme for Italy. The Veneto region has been one of the first Italian regions to recognize the importance of this topic, adopting a regional law in 2017 to promote active aging at the local level. The actions Veneto is promoting in the framework of this law are diverse, targeting the areas of prevention, health and independent living, active participation, and lifelong learning. However, population aging is not only an Italian matter, but a pan-European issue, with 1,055,000 Europeans expected to be over 65 by 2040. As Europe's population continues aging, the incidence of cardiovascular disease is set to increase dramatically. Preventing, detecting, and diagnosing these conditions at an early stage is essential to keep European citizens out of hospital and in good health, while making efficient use of healthcare resources. This regardless of gender, income, or country. In Italy, over the years, a number of projects have been developed to tackle this issue and promote the prevention of cardiovascular disease. In 2013, for instance, the project CARDIO50, organized cardiovascular risk screening program for active prevention in 50-year-olds, was developed and coordinated by the Center for Disease Control and Prevention of Veneto, along with 22 local health authorities of 11 Italian regions. The project was a major achievement, labeled as a best practice at the European level, and therefore considered worthy to be transferred to other countries. Its success has led to the Young50 project, financed in the framework of the EU Third Programme for Health 2014-2020, which aims exactly to transfer Veneto region's Cardio50 best practice to 3 other member states, Lithuania, Luxembourg, and Romania. It is really a good performance from local health authority number 6 to scale up this example of Italia's excellence in the health and care system at the European level. Now let me spend a few words to introduce you the Veneto region Brussels office, which is one of the units of International Relations Department of Veneto region. Established in 1997, the Veneto region's delegation to the EU is the liaison office with European institutions, bodies, agencies, and stakeholders. The office carries out a number of strategic activities in all EU areas of regional interest, advocating and promoting the whole regional system at the European level. The Brussels office is actively involved with relevant European networks of region in the health and social field, specifically in EUREGA, which brings region together for better health. Moreover, since 2011, the Veneto Region Brussels office has been providing a help desk service to regional stakeholders to support their participation in European programs. I take this opportunity to mention a European project in the field of health and active aging, which involved the Veneto region that has just been awarded a grant by the Interreg Europe program. It is called CARES, Remote Healthcare for Silver Europe, and aims to respond to the rapid progress of aging of European citizens. The Italian partnership includes the local health authority number 7, Pedemontana, from the Vicenza province. We believe that sharing knowledge and best practices with our European partners is of key importance, specifically in such a delicate and complex domain as cardiovascular disease. Therefore, we will be happy to promote and enable the dissemination of the Cardio50 screening model for further adaptation and use through our networks. To conclude, allow me a little quote from the famous philosopher Erasmus: "Prevention is better than cure, and it all depends on us." Congratulations again to the Young50 Consortia. Your work is truly taking the right steps in this direction. Thank you very much.
Thank you very much, Annalisa. And now we have Yvette Azzopardi. She's a policy officer from the Directorate General for Health and Food Safety, DG Santé, at the Commission. And she'll be speaking to us from Luxembourg. Here she is. And I know that Nicola is going to help you with your presentation. Thank you.
Yes, thank you. Thank you so much. And well, good afternoon to all of you. I'm very delighted to be here with you for this final conference of the Young50 Stay Healthy project, which has come to an end after 4 years. I would like the next slide, please. Yes, I would like to set the scene first. Well, the Health at a Glance Europe report that was published in 2022 shows that there are worrying trends in the EU countries with respect to life expectancy. And we know the report actually concludes that the EU is facing an epidemic of chronic diseases and that cardiovascular diseases remain the main cause of death, followed by cancers. We also know that there is a gender aspect in that women continue to live many years longer than men in all EU countries. But what can be done to address these challenges? Well, the report suggests that a range of policies can help to reverse this trend and to increase healthy life expectancy. And it highlights in particular the need for better prevention and improved management of diseases. However, we know that EU countries spend on average only 3% of the total health spending on prevention activities. Therefore, we need to join efforts to address health challenges and also to make sure that we can identify and implement the solutions that we need to better prevent, detect, and diagnose and treat non-communicable diseases, including cardiovascular diseases. Could I have the next slide, please? Now, coming back to cardiovascular diseases, we know they are the leading cause of death in the EU and therefore cause disability, much suffering among EU citizens. And we also know that in addition to the burden and impact on individuals and patients, there are costs, and the costs of treating cardiovascular diseases are high. And as the EU's population ages, these costs are expected to grow. Therefore, the Commission has been committed and is still committed to supporting and assisting the Member States in preventing and managing cardiovascular diseases, namely through health promotion and prevention activities. Could I have the next slide, please? Well, in fact, the Commission presented in June 2022 the Healthier Together EU Non-Communicable Diseases Initiative, and this was done to support the EU member states to reduce their burden of non-communicable diseases. And this initiative, or let's say the first outcome of this initiative, was a guidance document or a toolkit which was prepared through a co-creation process between the Commission and the member states' competent authorities, with valuable input from a number of stakeholders. In fact, the outcome, this Healthier Together guidance document, is a toolkit for action that focuses on the major public health challenges. It identifies and lists the national needs and priorities, and also provides evidence-based actions to help EU member states to implement policies and increase the number of interventions on the ground in order to address these public health challenges. In fact, the guidance document presents the needs of the member states in key disease areas, and it covers 5 strands. And one of these strands is the cardiovascular diseases strand. So the guidance document supports and helps the member states by presenting best practices from the EU, best buys from the World Health Organization, research projects and practices that have been evaluated, but always with an emphasis on prevention and promotion. I would like to speak a little bit about the best practice portal through which the Commission supports the Member States in identifying best practices for further implementation and rollout. And these are identified under the 5 strands. The last call, which was carried out in February 2022, resulted in a total submission of 58 practices. These were evaluated according to a predefined set of criteria, and 15 were presented during the best practice marketplace in September 2022. And of these, the member states selected 5 for further implementation. This best practice process, therefore, allows the member states to choose and then decide if they want or wish to transfer them into their national policies. I know that Mr. Giovanni Nicoletti from the Ministry of Health in Italy will be elaborating on this topic in his presentation later on. Here I can also highlight that the best practice process will be continued under the guidance of the newly set up expert group on public health. And this expert group has replaced the steering group on promotion and prevention, the so-called SGPP. And the aim of this expert group is to advise the Commission on actions, initiatives, and to promote coordination between the member states in order to address the major public health challenges in the EU in a more collaborative and structured manner. Could I have the next slide, please? Therefore, as I said, the Healthier Together guidance is a toolkit with the aim of supporting the member states to work together, to collaborate. And the member states are now taking forward the agreed actions that are set out in the Healthier Together initiative with the financial support of the EU for Health programme, which is the EU's biggest health funding instrument to date. And under the EU for Health 2022 work programme, there is a joint action on diabetes and cardiovascular diseases, of which you will be hearing a bit more later on. And this joint action will take forward further collaborative action to support the member states again in addressing these challenges in a more coordinated manner. And this joint action should build upon the results and lessons that have been learned from the Young50 project. Just as a last point on the guidance document, this is an open document. Therefore, the Commission is willing and ready to review and to revamp it according to the needs and the priorities of the member states and also the latest scientific developments. Could I have the next slide, please? Under the Healthier Together initiative, we say that the member states showed a high interest in improving the prevention and early detection of risk factors and cardiovascular diseases through screening. In fact, the member states identified certain priority areas for action, and these include increasing awareness of the impact of cardiovascular diseases and empowering patients to prevent and to manage these diseases. We need to help our citizens to live healthy lives with healthy minds, healthy bodies, and healthy futures. And through the implementation of best practices such as the Cardio50 screening model, we can strengthen the prevention of cardiovascular diseases across the EU. And I'd like to thank you for your attention and also wish you a very fruitful and insightful meeting. Thank you so much.
Thank you very much, Yvette. That was really interesting for all of us. And thank you also for participating. And if you can remain connected, we'll be very happy. We now have Ugo Guarnacci. He is a project officer and he works at the European Health and Digital Executive Agency, HADEA, we call it, at the Commission. So would you like to come and the floor is yours? Nicola will put it out.
È un po' laborioso, ma ce la facciamo. Un po' sfogato. So good afternoon, everyone. It's a pleasure for me to be here. I'm Ugo Guarnacci, as a program manager of the ADEA agency, which is a newly created agency of the European Commission, dealing with a set of EU-funded programs spanning across the digital and the health priorities. I'm also coordinating in the ADEA the team for non-communicable diseases, and that's why I took a set of projects, including Young50, which I'm gonna explain you how it fits within, of course, the priority that my colleague Yvette just explained from the policy perspective. I would like to give you a hint on where you sit vis-a-vis the programs and the project funded throughout the EU for Health program. So as you see, the structure of this presentation would like to join the dots between your project as ending and this final conference, I think, has been structured also in a way to connect different initiatives and projects that have been funded throughout the EU. So we will focus on Young50 vis-a-vis the third EU health program, understanding what are the other projects that we still have from the legacy portfolio in ADEA. And then I'd like also to provide you an overview from a helicopter perspective on the grants funded so far under the calls 2021 and 2022 of the EU for Health program. Of course, you will need to stay with me and bear with me because we're talking about a project that's been recently funded. So it's very soon to actually come here. It will be quite pretentious to give you an overview of the results, but we are very helpful that this actually will be what will come in the next month, because this project, of course, are beginning and start to build on the best practice that Yvette was mentioning before. And last but not least, I would like also to give you a hint on how this project and the result of the project could actually be used by future action that we're going to fund throughout the Hannover program 2023 as well. So if we start with the legacy projects, we still have as ADEA a portfolio of 60 million euros, covering 3 main areas. Starting, of course, from cardiovascular disease, we have 2 action grants, of course, your project, Young50, and also EUPAP, which is a project devoted to physical activity and prescription. And I know you involved today the project coordinator as well, because this was indeed a sister project. So we are very happy that in a line of project portfolio perspective, you're already joining the dots even throughout the agenda. We also have 2 important actions on nutrition. One joint action called Best Remap, which is about the healthy food for a healthy future, and is led by Slovenia as a member state, and also a grant, an action grant that came to an end recently, was EU grain on EU grain diet, involving some member states, and piloting action also in Romania, for instance, that is also involved in your project. And I think these 2 actions are quite relevant for the parts of Young50 that relates to, for instance, diabetes and healthy diets, which is indeed an important area covered by your action grant. Last but not least, of course, this is less relevant for Young50 as such, but we could not forget another important area of work that we have still from the 3rd EU Health Programme, which is mental health. There we have a joint action JA Implemental that is led by Greece and is linked to another action grant, EAD Best, looking also at important issues such as dementia and the prevention of suicidal behaviors. So what are the key projects that we have now ongoing from the current EU for Health annual program? So if we start with the annual program 2021, we have 11.6 million euro devoted to non-communicable diseases. So this part of the presentation is all about NCDs. And you see yet again 3 main areas coming up. One on diabetes, where we have just launched our joint action care for diabetes with 4 million euros, led by Spain, which yet again will of course take into account some of the key results that you highlighted from your project, and that Young50 was even acknowledged at proposal stage within the bulk of project when mapping the state of the art of best practices that this project was indeed presenting. We have 2 action grants on mental health for a total budget of 1 million euros, and then a bulk of 4 action on healthy lifestyle for all, which is also very important because we have one joint action health for EU kids led by Greece with 3 million euros and 3 action grants that they all have a focus on school environments. These actions are particularly relevant for us because they sit within the EU-funded action that contribute to the European Union of Youth. So there is also focus by age group, as your project Young50 was tackling a particular specific age group. Also those 4 action and the healthy lifestyle for all look specifically at kids and youth in different European countries and settings, including school settings. If we go now to the annual program 2022, I would like to focus now on the ongoing grants. Why ongoing? Because we're still evaluating a series of action from the annual program 2022 in ADEA. So the one you see listed here is the one we've already signed for a total budget of 11.1 million for NCDs. Mental health has been quite prominent in 2022 annual program, also to give relevance to an important aspect of mental health assistance for Ukraine refugees following the Russian war of aggression against Ukraine. And therefore, those projects always tackle very specific vulnerable groups, including not only refugees, but also internally displaced people. And in there, we have 4 action grants with a total budget of 3 million euro. We also have a different allow me to say, NCD within the project funded under 2022 that doesn't really stick in the 5 priority area that Yvette was presenting before, according to the Healthier Together NCDs initiative, which is the chronic kidney disease. And we were happy to see that under the prevention of other NCDs, this allowed us to fund a project looking at CKDs and therefore the chronic diseases, chronic kidney diseases spectrum of illnesses. Last but not least, within the bulk of grants that we manage, there is the joint action, the direct grants to member states, the action grants, but we also have operating grants. What are operating grants? They are specific grants given to NGO working in the health field for the functioning and operational activities. And here we have an important grant given to European Food Information Council, EUFIC, that did a fantastic job on delivering food fact for healthy choices, in particular looking at labeling and how labeling is actually influenced consumer behavior in different settings, looking also at how consumers can modify their choice according to the information they're given. Now we go to something that is highly relevant, was slightly mentioned towards the end of the presentation of my colleague Yvette. How does Young50 sits vis-a-vis the future actually action that we will have that are currently under evaluation? When I say currently under evaluation, clearly means that we'll not be able to disclose further information, although when we look at the joint action on prevention of NCDs, cardiovascular disease and diabetes, that has an important budget of 53 million, I'm happy that we have Graziano and Benedetta here today that will be giving you, of course, some details on this action at proposal stage as it was submitted, taking the caveat that, of course, things may change during the current evaluation, and they will be, of course, informed accordingly. So Italy is leading on this joint action, and this joint action is also linked to another one on cancer and other NCDs prevention, with a focus on health determinants, with a total budget of 75 million euros, out of which 25 million euro are devoted to the NCDs component specifically, so more than cancer, of course. This joint action is coordinated by Norway and is also under evaluation. As you see, these two joint actions are kind of twinned with two open call for action grants, one again on the health determinants with a total budget of 11 million, 8 for cancer, 3 for other NCDs, and actually a call for action grants on prevention of NCDs with a focus specific of cardiovascular disease, diabetes, and other NCDs with a total budget of 5 million euros. So you see that today we finish your project, but actually the seeds of Young50 are quite prominent in not only the ongoing project, but also in this action that I just listed that are currently under evaluation. I think it's important to also mention that, of course, in this action under evaluation, there is even a more prominent focus on the different health determinants that we have, but it's also important from a program management perspective to highlight that there is emphasis put on health equity, and in particular on health inequalities. I mean, all these projects that come to list are also requested, in particular the action grants, to have a work package, a mandatory work package on equity, in order to look at how different vulnerable groups spanning across Roma, refugees, disabled people, LGBTI plus, women, and so on and so forth, have different access to the health system and experience inequality in a different manner. So it is also important to mention that actually within the NCDs, EU for Health put particular relevance to equity and health inequalities. Now, just to conclude this presentation, I think we cannot, stop to give you an overview without scanning the future horizon. And therefore, I think also, because you just finished a project doesn't mean that you cannot apply anymore. Actually, it's on the contrary, you have the maturity and the expertise also as a region within Italy to do so. So we invite you to look at the Endeavour program 2023, where we have a kind of a similar structure of the one I've just presented for the call and evaluation. We have 3 joint actions, so member state-led actions, one on chronic respiratory disease. So this is the first year in the Endeavour program of EU for Health that chronic respiratory disease are tackled. Then we have a joint action on mental health and another joint action more specific on dementia and other neurological disorders. Linked to this, we have 3 open calls for action grants. One, again, on chronic respiratory disease, one on mental health, where you see there is also a specific focus on Ukraine displaced people, and one on dementia and other neurological disorders. Another important aspect to be mentioned is that for the annual program 2023, you will find reference on mental health also under the strand that is devoted to cancer. Indeed, in there you will find an open call for action grants on mental health challenges for cancer patients and survivors. So you see that the NCD's topics are really quite well represented even in the annual program 2023. Of course, just not only to be corporate, but also to actually be helpful. I think it's not only speakable, but also recommendable to have a look at their website, where not only we publish the annual program 2023 with the different calls, not only the one on NCDs that I've just presented, but also the different workshop and info session that we keep organizing with the help of our colleagues in the Parent DGs, DG Santenera. And also, I think it's worth mentioning that we have a network through a joint action that was funded during the 3rd EU Health Program, the joint action on the national focal points, NFPs. And I'm glad that Dr. Nicoletti is represented today here in this conference as well, because they are also doing an amazing job in helping applicants in the different member states to understand the challenges between in applying to the different grants that I've just presented according to the nature of the applicant, being them research institutes, universities, NGOs, or Ministry of Health in the member states and associated countries. Before concluding, I would like yet to really say that was a pleasure for me to follow. It's one of the few projects I have as a program manager to actually being able to follow you during the last part of the project. I know that you've been through a big challenge as well, a global challenge like the COVID-19 pandemic that nevertheless did not stop you from developing your activities. I'm pretty confident that if that pandemic was not there, your results would have been even greater, but that has not actually stopped Young50 to be a success stories for us. So a big thank to the Veneto region again, to the coordination team for the fantastic job you've done, for the link with the sister project. And again, I wish all the best also for the seeds that you planted to be taken by some other action that are well represented today in today's agenda. Thank you very much for your attention.
Thank you, Ugo, for your interesting presentation and also for your kind words to our team, because we really need them, actually. Okay, to go ahead now, we actually have our keynote speech, and I'm really very happy to introduce you to Claire Farrand. She's from the WHO, from the Nutrition, from NCD Euro team, and she'll be addressing this, thinking and addressing chronic non-communicable diseases, challenges, and WHO's responses. Thank you very much, Claire, for being here. And you'll have your presentation as well.
To just go ahead. Thank you. Oops, I think I. Lovely, thank you. Thank you, Elizabeth, and good afternoon. Can you hear me okay? Yeah. Yeah, and good afternoon to everybody. I'm delighted to be here on behalf of WHO, and thank you for the invitation to join this event, and congratulations for your success on this project. My name is Claire Farrand. I'm a public health nutritionist, and I work as the Technical Officer for Nutrition at the WHO European Office for the Prevention and Control of Non-Communicable Diseases, which I'll probably refer to as the NCD office from this point forwards. So I work within the nutrition, obesity and physical activity team, and our main role is to support member states on the development and implementation of policies to promote healthy lifestyles throughout the life course, including improved nutrition and increasing physical activity. Today, I'm going to talk about driving policy and delivery of action at the national level. And as part of that, I'll be introducing a relatively new tool that's been developed by the NCD office to support member states and practitioners to strengthen our actions using systems thinking for NCD prevention policy. I'll then spend a little bit of time at the end of the presentation going through some of our key areas of work. This isn't comprehensive, but just to give you a flavour of some of the activities that we do. So as you will have heard already this morning, non-communicable diseases are the leading cause of death and disability in the WHO European region. And you can see here, as illustrated on this slide, it's significantly so. Unhealthy diets, excess body weight account for a large share of the non-communicable disease burden in the region. And our region is really strongly affected by the challenges imposed by childhood obesity, overconsumption of foods high in salt, fat and sugar, low consumption of fruits and vegetables, tobacco use, alcohol consumption, and physical inactivity. We know that NCD risk factors have a series of determinants which are interconnected. And it's very highly unlikely that a single intervention will give an outcome that we're trying to achieve, which is reducing that risk factor at the population level. Therefore, we really need to take an approach to problem solving that views the world as a complex system of interconnected parts, rather than focusing on the individual components, and consider how these parts interact and influence one another to create the whole. And this is what is considered as systems thinking, and it's included in all of the WHO action plans to implement interventions to address NCDs. So we hope that understanding the whole system and deciding our policies within that context will hopefully improve our implementation. So with that, we have developed a manual or a guide that we're calling Systems Thinking for NCD Prevention Policy. We know that applying systems thinking in policy and practice can be challenging. And while many policymakers agree with systems thinking in principle, they might actually struggle to see the practical utility of it in their work. And so really the intention behind this tool is to help interested practitioners and parties to learn about a range of systems approaches that might be relevant for their work, and then to assess their suitability whilst considering the resource implications and obviously their benefits. The guide is very much a foundation and introduction on how to make decisions and use systems thinking methods and how they can be used within during the policy process. The guide also contains a decision aid to support practitioners in navigating those range of different systems methods based on the stage of the policy cycle that they're in, and also what resources they have available. A little bit more about the manual. So systems thinking can be quantitative or qualitative. The approach will often depend on the issue that's being addressed, the resources that are available, the proposed project's timescales. And it really allows for the identification of different leverage points, unintended consequences and feedback loops, as well as some of the non-linear relationships of changes. Now, we know that those leverage points are points in a system where a small amount of change can lead to a significant system-wide impact. So through the identification of these leverage points, it's possible to maximize the success of a policy. those unintended consequences, which many of us may have seen in many of our projects, are responses in a system that occur as a result of a policy change that may have been hard to predict without the adoption of a systems approach. And these consequences can either be beneficial or detrimental, and they can help us to understand the wider scale impact of a policy in a real world setting. And the feedback loops can exist within the system, mean that changes to one part of the system may affect other aspects of the system. So this manual takes you through each step of the policy cycle and provides a description of how to use this concept within each phase, from problem identification to analysis to policy development, implementation, and through the monitoring, enforcement, and evaluation stage. There are many systems methods, and I've included some of them on the slide here. Many of you might be familiar with them already, from cognitive mapping, systems dynamics modeling, group model building, network analysis, and qualitative comparative analysis. And I mentioned that the manual also contains a decision aid, so helping those practitioners through the different steps by identifying which part of the policy process you want to apply the systems thinking to, what level of resource is available, and then it helps to identify what the appropriate approach might be. So in an example here, so what policy measures can we take to reduce the quantity of sugar in a nation's food supply? Identifying at the policy stage, trying to clarify and frame the problem that's to be addressed and identify the different policy options. And then using the relevant systems approach. So as identified here is cognitive mapping, systems dynamics, agent-based modeling. A variety of qualitative and quantitative systems approaches are outlined in the manual, and the details of the advantages and disadvantages of each approach are also provided along with an overview. The manual also contains, and I think this is particularly helpful, is those real world examples of how systems thinking approaches have been implemented at the local, national, and also at international levels for a variety of the NCD policy areas. So that includes tobacco control, obesity prevention, urban health, and nutritional outcomes from a range of the global regions. So putting this now into the context of nutrition, nutrition is a really complex issue. It involves a wide range of factors, including social, economical, and environmental factors. And so by applying a systems thinking approach to nutrition, we can better understand the underlying drivers of malnutrition and develop more effective interventions. Unhealthy diets are a leading risk factor for Europe in the WHO European region. Food systems are the largest anthropogenic driver of biodiversity loss. The food system accounts for approximately 34% of annual greenhouse gas emissions. Agriculture is responsible for 70% of freshwater withdrawals. Global food production is the single largest human pressure on Earth. And the high cost of unhealthy diets, coupled with persistent high levels of income inequality, are putting healthy diets out of reach for many people in every region of the world. Many of you may already be familiar with this slide, using obesity as an example of a really complex multifactorial disease. To date, there's been many studies done on obesity and its causes, which really very broadly summarized in this slide. As you can see, obesity is not just about energy in or food consumption and energy out individual activity. there are many more factors involved, such as individual psychology. Examples of that include self-esteem, stress level, food literacy, and many factors outside of the individual's controls. And these include the influences from society, such as social media, peers, family influences, and also food production, such as the price of food, portion sizes, not to mention individual biology, and the activity environment that plays a huge role. For example, accesses to green spaces in your environment, or access to affordable gyms in your area, or are the roads safe to cycle on or walk on, etc. So this really demonstrates how obesity is a multifactorial problem, and interventions need to take place in all of these spaces to stop the obesity epidemic. So we need to start moving from a traditional approach to a systems approach. Sorry. Oh no.
I thought I wanted to hide that.
I think it should just be, oh, go ahead.
Share.
Okay.
Hide. No.
Okay.
And then,
Can you see? Yeah. See.
Yeah.
Okay.
thank you.
Yeah, thanks.
Thank you.
Sorry.
Thank you. So we need to really be moving from a traditional approach to this systems approach. So moving from siloed working to thinking about simple and complex systems, moving from generalizing about our policies to improve risk factors to very tailored activities within that specific context, moving from individual isolated activities to a shared vision and aligned actions and prioritization of actions, moving from that linear cause and effect to a dynamic approach using that feedback loop, understanding the unintended consequences, and also ensuring leadership at all levels. I'm going to use the next few slides, as I mentioned at the beginning, to highlight some of the work that we've been doing to address some of these challenges. So developing some of the tools and resources for member states to use to address some of the challenges that we face at different levels. This year, the NCD office last year, my apologies, launched the WHO European Regional Obesity Report for 2022. And this report looked at all of the different factors influencing obesity across the life course. And some of the factors that I've highlighted here on the screen, which relate to diet specifically, look at policies to address unhealthy foods, our access to unhealthy foods, and our decision making. And some of those some of the WHO tools that we have looked to develop, or technical tools we've looked to develop, are around taxation for unhealthy foods, marketing restrictions, including digital, subsidies for fruits and vegetables, mandatory front of pack nutrition labels, mass media campaigns on healthy diets, regulations on food outlets, and healthy public food procurement and service policy. So just looking at these in a bit more detail. The NCD office launched a publication on a policy brief and model law on effective regulatory frameworks for ending inappropriate marketing of breast milk substitutes for infants and young children. And this comes in addition to the 2019 draft model nutrient profile for foods for infant and young children. So understanding that if we create an environment, or if we promote give the best chance for children at the early stages of life, this will track through to adulthood. So really trying to implement policies, or support member states to implement policies that will have the biggest impact at the earliest stages. The second tool that you might already be familiar with is a tool for monitoring children's exposure to marketing of unhealthy products online. So this we refer to as the CLICK framework. This framework is intended to collect data on exposure of marketing of these unhealthy products to children, and then to ensure that we're able to implement the policies to restrict this marketing of unhealthy products to children in the WHO European region. We also have the WHO nutrient profile model. The nutrient profile model was developed in 2015 to reduce marketing pressure to children of foods high in energy, total and saturated fat, trans fats, total and added sugars, and non-sugar sweeteners, as well as salt. And we are updating this model currently, and we're looking also to extend this model. So we've done an update on the nutrient profile model on baby foods that I just mentioned. We're looking to update this model and extend this model beyond marketing to also be used for front of pack labeling. And we're having some discussions on using a nutrient profile model for healthy and sustainable diets within our healthy and sustainable diet work stream as well. Another one of the manuals that we've developed is this food procurement manual. So understanding that different settings like public institutions such as hospitals, schools, workplaces are a good opportunity to lead by example and influence behavior change. And so we have worked with experts and colleagues within WHO to develop a food procurement manual which not only brings in healthy diet, but also sustainability. So working with experts in Denmark who are leading the way in terms of food procurement for both health and sustainability within these public institutions. We've also developed a manual on brief interventions for non-communicable disease risk factors in primary care. Brief interventions are recognised by WHO as an effective measure to help people quit tobacco, reduce or stop alcohol use, and increase physical activity. And they can also be used to help achieve and maintain healthy eating behaviours and manage weight for those living with overweight and obesity. Management of obesity in children and adolescents in primary care settings. So we're working with experts in this area to develop guidelines and a practical training package. And finally, whilst this isn't comprehensive, I wanted to highlight the importance of collaborations. So understanding that within the system, it is important to have strong collaborations, and we have been working very closely with our behavioural and cultural insights team within WHO, which is one of our flagship initiatives, trying to understand what the different contextual factors are that might influence some of the implementation of some of our policies, and bringing those into the development of the tools that we're developing at the early stage. We're working with within implementation research for school nutrition. We have developed a marketing network, a sugar and calorie reduction network, and what's not included here is also our salt reduction network, which has been in effect for at least 10 to 15 years now. If you're interested in downloading the Systems Thinking Manual for Non-Communicable Disease Prevention, I've included the links here. I am happy to share this presentation or have this information circulated so that you can access these documents more readily. And I wanted to just reiterate as well that whilst systems thinking is included in all of our NCD action plans, it is also something that we're incorporating into the development of new work that we're undertaking, including we have a new work stream on climate change and NCDs, understanding that we need to create solutions to complex problems that are influenced by a range of dynamic factors. and that this manual will really support policymakers with practical decision making on the benefits and the limitations. I will finish in the next couple of slides by just illustrating, I wanted to illustrate the new work that we're doing on non-communicable disease and climate change using one of the systems methods. So this causal loop diagram here, sorry, this was produced by colleagues within the team as part of the exploratory phase of looking at NCDs and climate change. So the NCDs, I'm a bit afraid to touch the screen in case I change the presentation, but NCDs are highlighted there in green. The NCD risk factors are in yellow, if you can see them clearly. The natural environment is in purple, natural disaster event in red and pink. Economic activity and climate related outputs are there in, I think it's in grey. Further to this, we are also hosting a summer school on NCDs and systems thinking, and I believe that's being held in Nice in France later this year. And this summer school is focusing on using a systems approach to the promotion of healthy lifestyles for healthy aging across the life course. And the school will support participants in understanding the systems thinking theories, the techniques and the tools, and how to apply a systems-based approach to strengthen the multi-sectoral collaboration across these complex systems, as well as identifying common patterns in complex systems and how to mitigate them to implement policies and strategies more successfully. So we're looking forward to hosting this school later in the year, and hopefully this is one of many. So that was just a quick round trip on some of the activities that we have, and drawing attention to our new manual on the systems thinking. I am here until I think early this afternoon, so if you do have any questions, I'm around and I'd be happy to answer any of them. Thank you. Sorry.
Thank you very much for this all-around presentation, Claire. And as she said, if you have any questions, she's here to answer them. Now, to go ahead, we actually have a colleague and friend, Giovanni Nicoletti from the Ministry of Health in Italy. He'll be connecting via the net, and he's going to talk to us about the assessment and the replicability of best practices in Italy. Thank you, Giovanni, and welcome.
Good afternoon, Liz. Good afternoon to everyone. Regretfully, my video is out, so you will forgive me if you don't see my face, but I guess you don't lose so much. I was wondering if you can show my slides, or should I do it on my own?
If you want, Giovanni, I do it. It's Nicola speaking from ProMIS.
Yes, please. I think that will be easier. So thanks, first of all, thanks for this invitation. I have a very short presentation, but too many slides, so we will go very rapidly. And the sense of my speech is, first of all, to have a snapshot on where we have been compared to the start of this project. And as it was already mentioned in the initial presentation, Young50 and sister project on prescription of physical activity were the first two projects supported by the third European Health Programme in the frame of a more general approach to promotion of best practices. If we can go to the next slide, please. The cycle of the best practices, this is an old slide, but in practice it has been left as it is in this slide for years. And after the first two projects, we have been several rounds of this cycle, always be concluded with the selection of some potential projects to be supported by the health program. The next one. This is probably not very updated, but just to show how many initiatives have been run within this frame since the very first. The next one, and this is some conclusions which are provisional. Probably we should still work in the frame of the newly instituted public health expert group to fine-tune these conclusions on how this process was effective and productive. These are reflections that have been produced by an external reviewer in the frame of a contract with the Commission. Anyway, the main results are considered very positive, even there is a need maybe to reflect a bit on the whole process, which is somewhat lengthy, and on the initial selections on the practices to be included in the cycle, because probably some more innovative and potentially very interesting practices maybe not getting into the cycle as it should be probably appropriate. But passing now to Italy in the next slide, I just want you to show that as many other countries, we have also some similar tools as those that have been already mentioned. We have in place in several years this database on the project on prevention and health promotion, which is a very large collection, is coordinated by the Piedmont region in the next. And more recently, the next one, please. More recently, in the bigger frame of the nation, on the regional and national prevention plan, the Ministry of Health and the National Health Institutes have set up a web-based platform, which, among others, the next slide, is including a repository, not just of good practices, but more in general, a list of potential actions that the regions can consider in their regional plannings on prevention. So in practice, as you see, there are a lot of resources that are in practice ready for use if the regions want to include them in their regional plans. So something that looks a bit like what we have done at the European level, but probably with much more practices and much more possibilities to include adaptation to local context as it should be. The next one. Getting a bit more in detail about what happened to Young50 and in particular to the project that we call CARDIO50 that was launched in Italy several years ago. And as you see, initially, we had 2 rounds of support by the National Health Fund that is managed by the Ministry of Health. And at that time, with objectives which are more or less the same as in Young50, we had enrolled several thousand people in practice, most of the regions, initially 6 and then 11 in the second project. So a very large population and a very large number of regions. But what happened afterwards, as mentioned, the next one, the particular sector of cardiovascular prevention became a structural part of our national prevention plan. We have had already several rounds of the national prevention plan. We are now in the 3rd, but as you see, even in the first, from 2010 to 2012, cardiovascular prevention and identification of cardiovascular risk factor in individuals, early identification, was already one of the main objectives. The next one, coming now to the actual, the present National Prevention Plan, which is going to expire in 2025. Once again, intervention at identifying individual risk condition for NCDs are listed among the big priorities within the big frame of NCDs. The next one, and now we however have some information because the Ministry of Health collects the regional prevention plans and gives a sort of feedback evaluation to the regions. And so we have several data on what actually regions do within the frame of their regional prevention plan. And from our monitoring system, we see now that in practice, only 3 Italian regions still run projects mimicking or respecting the CARDIO50 traditional, let's say, or original approach. The next one, a few more probably do not respect exactly the objectives and the methodologies of CARDIO50, but still are working on something that looks a bit similar on NCDs and cardiovascular screening. And the next one, and then a larger number do not run specifically projects on cardiovascular early detection, but let's say a more general approach oriented to disease prevention that in itself might include, and for sure will include, also actions on NCDs and cardiovascular. Based on this information, the next one, I try to draw some lessons from our experience, and some are good lessons and others maybe a bit less. Starting from the good news, the role of having best practices proved essential both in European and Italian experience in setting the scene. What I mean to try to find concrete proposals, in particular for the units in the national health system that did not have a particular background or previous experiences. Clearly, there's a need to have a standardized approach and the ability to support in programming and project designing, which exactly is the main scope of our national prevention plan, but in practice also of the European Health Programme, which obliges you to have clear objectives, outcomes, and impacts. The next one, getting to something that is less positive, this experience proves that regretfully there is no possibility after the, let's say, the starting phase, the startup process, to leave the local units completely alone, neither from the point of view of the expertise and even less from the point of view of the financial support. This is clearly a key, these are key problems for the sustainability of any projects, but it's something that we have been able, at least to a certain extent, to provide. And clearly, this is not as easy in the European scenario. The next one, and regretfully, there are even worse news that in several regions, despite national support and evidence of well-functioning effectiveness of these programs, local implementation is no longer in place at the moment. And say very alternative choices, to a certain extent, have been made, and even more regretfully, not in every situation we are able to understand really what happened. Probably there have been staff turnover, there will be changes in the political governance. In any case, apparently several of the causes of long-term failure cannot be prevented. This is a matter of fact, despite its very bad news, we have to accept this concept and try to work in order to take in account this challenge, at least in Italy. The next one. So trying to draw some suggestions for the future. Clearly, probably we have to focus on objectives more than on specific actions or practices. This is clearly something that can sound not so good, but probably there is not a one-size-fits-all solution, in particular if we consider different countries. And I'm very interested to hear in the second part of the conference how this situation was managed in your project, in particular adaptation to individual country needs was implemented. The second point is that probably once again having a continuous networking of people which are doing the same job probably is a value in itself and can provide more sustainability than establishing once in life that something should be done in a specific way. We are trying to find and to find how to say some follow-up of this concept in our monitoring of the regional prevention plans. And I was wondering if in the new group and the commission could take care of trying to take this lesson in the new process of the good practices also at the European level. The next one is just my contact, and the next one is the conclusion. And I want to thank you for your attention, and I'm glad to answer questions, if any, in the next part of the conference. Thank you very much, and good afternoon to everyone.
Thank you very much, Giovanni, and also for supporting us in this project. So now we come to our next presentation. It will be done by Dr. Graziano Onder, I guess, and also with her Benedetta Ermocida. They are from the Italian National Institute of Health, and they'll be speaking about the new Giacardi Joint Action Project. Thank you for being here, and you're welcome.
Thank you for the invitation. So let me start saying that the Giacardi project is currently under evaluation by ATEA. So not all the concepts I'm going to present here will be necessarily included also in the final version of the proposal. But overall, we would like to provide you with a general overview of the project, the thoughts, the ideas, the concepts that are underlying the project. As said, the project is led by the Italian National Institute of Health, the Istituto Superiore di Sanità, and Benedetta and I will be leading the project. So. Thank you. Bye-bye. Perfect. Giacardi project answers to a call released in 2022 that is specifically focused on the topics of cardiovascular disease and diabetes. The aim of the call of the joint action was to reduce the burden of non-communicable diseases and risk factors, both at a personal and societal level, targeting or addressing the specifics of cardiovascular disease and diabetes and their health determinants. The overall EU funding for this project is, as Ugo has said, 53 million euros. As you may know, this project have co-funding of around 20% in this case. So the overall funding for this joint action is 66 million euros. And this is clearly one of the largest projects, but Ugo has already said that, ever funded by the European Union. So why the focus on cardiovascular disease and diabetes? Well, you all know probably better than I do that non-communicable diseases really are a challenge for our healthcare systems. 86% of all deaths in the WHO European region is due to non-communicable diseases. 115 billion euros spent every year for the care of these conditions. And among non-communicable diseases, clearly cardiovascular disease and diabetes have a prominent role. Cardiovascular disease are the leading cause of deaths in the EU. 63 million people living with these conditions in the EU. Same for diabetes. Its prevalence doubled in the last decade. More than 32 million people living with these conditions. Also, let me say that these are not conditions that only happen in older adults. We know that their prevalence progressively increases with increasing age. So the rate of this condition is higher in older adults, but really this may be easily found also in younger adults, and the overall and absolute number of people suffering from cardiovascular disease and diabetes is probably higher in those younger than 65 than in the older population. So having said this, we tried to build a project focused on several key aspects and key consideration. First of all, first keyword, implementation. We wanted the project to bring some changes at the local, regional, national level, and to implement something or some activities that are probably lacking in this context. The second keyword is standardization. We live in a very heterogeneous Europe. Even within individual countries, there are huge differences and heterogeneity. We want to try to standardize as much as possible the approach to some topics related to these two conditions. We are not proposing to standardize the intervention in this joint action, but what we are proposing is to have a standardized methodology or approach to make the change and to fill in the gaps that are different from country to country, from region to region. So a standardization not of the intervention, of the implementation, but of the approach, of the methodology that is used to make a change. Third key concept is to build on what already exists. We do not have to reinvent the wheel. So we want to build, and we did it. I believe we were successful in doing this, on already existing national and especially international projects that were performed in the last decade. And the project was very much focused on needs of and priorities of member states. The topics that were touched and considered in the joint action were topics that were underlined by member states and the representatives. So we tried to consider these aspects as much as possible. And last but not least, what I usually say to the partners and our colleagues participating, let's try to shoot high as much as possible. We, again, have one of the biggest project ever funded in this area, so we really have to try to make a change at the European level. These are the JCARDI scope and general objectives. So to reduce the burden of cardiovascular disease and diabetes and related risk factors, to improve health system sustainability and equity, to enhance and promote the implementation of best practices and pilot testing of innovative practices throughout the whole patient journey, and to work both at an individual and population level. These are the topics that are addressed by the joint action that span across the whole patient journey, moving from health literacy and awareness, primary prevention, focusing on care pathways, self-management, and labor participation. That is also another important aspect that must be considered, that is considered in the joint action. Overall, health equity and data availability and quality are two aspects that cover all these sectors that are consistently considered in all work packages and activities performed in the project. So this is more or less the structure, This is the structure of the project. As every joint action, there are 4 horizontal mandatory work packages that are focused on coordination, dissemination, sustainability, and evaluation. But the main body, the main area of the joint action is characterized by these work packages that are numbered between 5 and 11, that are focusing on the main areas, main concept we want to address: health literacy, data and registries, screening, care pathways, self-management, and the labor setting. All these sectors are somehow supervised or influenced or driven by this Work Package 5, that is the methodological framework. We really want to build a standard methodological framework, and all the intervention should follow this methodological framework that is defined in this Work Package. Benedetta will later on show you what are the concepts underlying this methodological framework, very much inspired to the theory of change concept. I'm going quick through this because these are all the areas addressed under the 6 technical work packages that again are addressing health, literacy and awareness, data availability and registries, screening, integrated care pathways, self-management and labor participation, but I'm not going in depth into this. Another key aspect of the joint action is that it really includes many member states, 21 member states. Many of them are implementing more than 140 implementation. Benedetta will show this to you later on. And also many member states are strongly involved in the coordination and leadership of the joint action. So beside Italy, that clearly coordinates the whole joint action, we have Hungary, Finland, Poland, also Ukraine leading or co-leading one work package, Slovenia, France, Spain, and Belgium. So all these countries are involved in the coordination or co-leadership or co-leadership of at least one of the work packages. As I said, the joint action Giacardi builds on already existing projects. So we are very happy to say that the overall approach follows the orientation of the Healthier Together EU Non-Communicable Disease Initiative, but also there are many projects that are involved and considered, and also partners in the joint action have already participated in many of these projects. CRODIS Plus, joint action on health equity Europe, JADA Care, Care for Diabetes, Best Remap, EU Stop, and also Young50. So clearly this action puts together all the knowledge built by this project and bring it forward to a next level. I now leave the floor to Benedetta to complete the presentation.
Thank you very much, Graziano. Thank you very much, everyone, for the opportunity to be here. The second part of the presentation, we would like to highlight the added values of Giacardi and also the impact that we envisage that we would like to provide for a better public health and prevention and control of NCDs. The first added values is the wide geographical coverage. As Graziano was mentioning, as you might see from the map, we will 21 member states will join the Giacardi joint action, and I would like to highlight the active participation of Ukraine, as Graziano already said, and we will have a total of 77 partners. The second added value is that the pilot implementation will reach millions of people. In this summary table, we wanted to highlight for each technical working packages, we try to summarize both the macro area that we are going to cover. As Graziano was said, we already predetermined a specific thematic area that needs to be covered in each technical working packages. We also try to see which are going to be our target group, from general population to specific target group, including vulnerable population, migrants, pregnant women, adolescents, and elderly. And then we also already try to estimate how many people we are going to reach through our implementation. And as you might see, we will reach millions of people. As Graziano already said, we are going to implement more than 142 pilots covering 18 EU countries. And then the other added value that Graziano already mentioned is related to the methodology that we are going to use. We are going to harmonize. There will be an harmonization of the approach for the pilot implementation, a standardization of the multidimensional assessment of the outcome and scalability of the pilot project, The pilot implementation will be based on unmet needs and best practices. And then the other added value will be the sustainability. Those methodological aspects I will explain in more detail in this slide, in which we actually would like to report the main activity that will be conducted in each technical working packages. So all the vertical working packages will cover those 4 main interconnected activities. The first one is the mapping and context analysis. So all the technical working packages will start with a map of the challenge, needs, and priorities at country level or regional level. There will be also an analysis of the identification of local links, as well has the selection of relevant intervention. And as Graziano was mentioning, we will have working package 5, a methodological working package that will give a common methodology to do and to conduct this mapping and context analysis. And also will be based on previous joint actions such as CRODIS Plus and JE. The second activity that will be conducted is the preparation of pilot implementation plan. In this phase, all the technical working package will prepare and fine-tune through evidence-based intervention that will be selected, a tailored and specific implementation plan for each pilot site. We will select best practice from the European Commission Best Practice Portal, as well as cost effectiveness intervention. Those interventions will be evaluated by an implementation board, which will be established in Working Package 5. So we will have a common methodology to address intervention and key elements that will be implemented based on the need at local level or regional or national level. So as mentioned, there will be a common methodology, and again, we're not going to reinvent the wheel, but we are going to use guidance from CRODIS Plus and Jade Care. The third activity is the pilot implementation. The pilot implementation will be supported by Working Package 5, so the working package from methodology. There will be a capacity building from Working Package leader and co-leader of Working Package 5 through the technical working package, and there will be a monitor and support of all the pilot implementation phase. Data, qualitative and quantitative data will be collected in this phase. And as mentioned, the methodology will be a common approach, a common methodology. And for example, we plan at least 2 cycle of plan, do, study, act cycles. Then the last phase will be the assessment of pilot. This assessment will be a multidimensional assessment of the outcome, both at health and economic level, and also the scalability. So we are going to develop a roadmap for scaling up the pilot. Also, for this assessment and the development of the roadmap, we are envisage a common methodology built in our Working Package 5, so in the methodological framework working package. And this assessment will be based on previous Horizon project, the EU STOP project. We also wanted to highlight the importance of sustainability, which each pilot site will have a sustainability plan that will be developed, and also the importance of science to policy interaction that will be based on JRC handbook. This is we wanted to report also how we envisage the management, the decision making, and the advising of the joint action. We included 2 advisory board, one scientific, one stakeholder board, and also we wanted to highlight how in the management we will be in connection with ADEA through the Working Package 1, as well as with the other joint action on health determinants in Working Package 4. The Working Package 4 on sustainability for the Jakarta joint action and the joint action on health determinant will be actually aligned. And then our target groups, we'll have a direct target group for sure will be patient with cardiovascular diseases and diabetes, and high-risk population with a specific focus on vulnerable population, as I mentioned before, migrants, refugees, disabled, elderlies, healthcare and public health professional, general population, policymaker, and employers and manager, considering our working package 11 based on the labor participation with people living with NCDs. Then the indirect group will be academia, patient organization, civil society representative, public and private enterprise sector. Considering what we envisage on the implementation of the joint action, we also try to report the short, mid, and long-term impact. The short-term outcome and the impact of the project would be, first of all, improved information, local needs, context, and an available best practice intervention on cardiovascular diseases and diabetes, strengthen local, national, and international stakeholder networks, strengthen awareness among EU countries on the added value of having a cooperative and integrative approach, improve the knowledge at different level and setting, and also support the capacity building of our consortium members in communication, science to policy interaction, as well as pilot design, monitor, implementation, and assessment. Then the midterm outcome are basically the improvement of what we expect, the outcome that we expect from our technical working packages. So as Graziano mentioned before, the increase of awareness and health literacy, improve the use of digital tools specifically within the patient self-management, improve the availability, quality, accessibility, and use of data in population-based registry on cardiovascular diseases and diabetes, and improve standardized evidence-based screening or integrated service pathway and self-management, and improve equal opportunities and labor participation of people living with NCDs. Finally, the long-term outcomes. Jacardi will contribute to the reduction of premature mortality from NCDs, improve equity. As also Ugo was said, we are going to base a common methodology also on the equity in health and inclusion, and strengthen national capacity, leadership, governance, multi-sectorial action and partnership, as well as transdisciplinarity to accelerate country response on the prevention and control of NCDs, and strengthen health system to address the prevention and control of NCDs with a specific focus on social determinants and people-centered primary healthcare and universal health coverage. Promote and support national capacity for high-quality data. And finally, as we were mentioning, considering the importance of having a common approach and a standardized methodology, the development of standardized approach to improve service organization. We thank you very much, and we are available for further discussion and questions.
Thank you very much, Benedetta, and also to Graziano. Now we'll be changing a little bit our presentations, because this was the first part where we wanted to have, sort of some new inputs, what's been happening, and also what we learn also from the policy and the presentation from WHO. We'll be now going into detail a little bit on what happened to our project. So we are going to introduce our pilot sites roundtable. So I'll ask the participants to the roundtable, which will be moderated by Anne. She's from Cronigune, Spain. And we'll have Lucia from Airport, Romania, Fabrice and Marie from Luxembourg, and Viva from Lithuania. These are our three partners. Please come in front. Thank you.
Good afternoon, everybody. First of all, before we start with the roundtable, I just spend 2-3 minutes to contextualize a little bit more the project, although I think that the previous speakers already have said something about it, and everything is quite clear. Well, as Elizabeth has said, I'm Anne Fullando from Chronic Wound Institute from the Basque Country in Spain. And as you know, the Young50 project started some years ago, 4 years ago, and the start was, as our officer Hugo Arnatzi explained, there was a survey among the member states of the steering group of promotion of health, disease prevention and management of non-communicable diseases, who selected some best practices to be transferred to different contexts in Europe, to different member states. And this was funded by the Third Health Program. One of the best practices selected at that time was CARDIO50 from the region of Veneto, which was focused on a sustainable, active primary prevention strategy for cardiovascular diseases for people over 50 years. So in the Young50 project, this CARDIO50 good practice has been transferred to Lithuania, Romania, and Luxembourg. And here we have the main actors of these transfers. The coordinator, as you know, is the region of Veneto. And the main objectives of the Young50 project was first to adapt and transfer the Cardio50 screening and prevention program to these 3 new contexts, these regions of Europe, to reduce the cardiovascular risk factors through changes in lifestyle, and of course to fine-tune the model to optimize the performance and sustainability, to try to maximize the spread of this program across different countries. So here you have the main structure of the project. We have the typical transversal work packages led by our coordinators, work package 1 coordination, work package 3 evaluation. We have ProMIS leading the dissemination activities. And then on the right side of the slide, we have the technical work packages. We have work package 4, where we analyze the feasibility of transferring Cardio50 to new contexts, led by us, by Chronic Wound. Then we have the adaptation of the app and other materials of Cardio50 program to new regions. This was led by Lithuania, work package 5. Then we have the implementation itself, the rollout of the local programs, work package 6, led by Luxembourg. And then we have Veneto again as responsible for work package 7, which is focused on trying to develop recommendations for the long-term sustainability of the program. So here we have the project timeline. It was prepared, the proposal during 2018, 2019, and 4 years ago, it was the kickoff meeting of the project. And in April 2020, the implementation of the screening program in these 3 new contexts was launched. But of course, due to the pandemic, the work was interrupted by 2 years, more or less. So in September, in autumn 2021, excuse me, the screening programs again were relaunched progressively. And right now we are just collecting all the data, trying to submit to the Commission the last deliverables with all the outcomes and the results that we had. So having said this, I'm just coming to the table, try to introduce. Thank you. So I will introduce again formally our participants, because Elizabeth has already said the names, but I will just say a couple of words about them. So we have there, I will start with Lucia Maria Lotrian from Romania. She is a medical doctor with a PhD in hygiene, and she is the project coordinator of the Romanian pilot site, and she's on behalf of AREPUR Romania, a non-governmental organization. We have Vaiva in the middle of the table. We have Vaiva Almasova from Lithuania. She's the Deputy Director of General Affairs in Centro Policlinica in Vilnius, in Lithuania. And finally, we have 2 colleagues from Luxembourg. We have Marie Leyot, project leader in epidemiology in the Department of Public Health Expertise at Luxembourg Institute of Health. And finally, here, last but not least, we have Fabrice Moers from he's the representative of the Ministry of Health of Luxembourg, concretely from the Directorate of Health. So thank you very much for joining. So I will start with some questions, trying to deepen a little bit more on the implementation experience they had doing this for years, I would say, because it has been a long journey with the pandemic, the invasion of Ukraine in the middle, so many challenges. So first of all, I will start with both of them, Romania and Lithuania, because as we will explain, the approach followed in Luxembourg is slightly different, but very interesting as well. So Vaiva and Lucia, first of all, congratulations, because you have managed to implement the local screening programs, which is not an easy task. You have faced difficulties, some challenges, and due to many factors. If you would start again, what would you modify to try to have better results, better recruitment rates in your regions? What do you feel that have not worked as expected? What would you change in your local action plans, let's say? Yeah, Lucia, please.
Hello, everybody. In Romania, the project was implemented by a non-governmental organization with a lot of experience and expertise in implementation and evaluation of different health promotion projects, and also with previous experience with different European projects. In the moment when we said yes, we would definitely want to join the team because we really believe in this project and its mechanisms and possible results. We were aware, even from the very beginning, that there are several challenges which in a way depends on the type of the activities we intended to implement, but also on the characteristics of the organization. Being a non-governmental organization, of course, you do not have other governmental institutions which could or should work for you. But on the other hand, we, in a way, I want to underline, succeeded to overcome this obstacle because of our networking and previous projects and cooperations with different governmental or professional organizations. And we were hoping and we were counting that this will help us. Then, of course, I saw during previous presentations, it's very important to have mechanisms, to have support and implications from different levels and funding, including the Ministry of Health from Italy, underlined that sustainability and even implementation before sustainability includes a very important compound of funding. And we had, this was very important, we had the European funding, but we had, as a non-governmental organization, we had a clear limitation, the 40% co-funding, which in Romania is not covered. There are not mechanisms for non-governmental organizations or universities to find possibilities or mechanisms, national mechanisms, to cover, to find a way to be covered by government. And indeed, with all this at the beginning, we said that we'll try to find ways to adapt the program and implement it, even if it will be a local, regional level, not national level. This was our first intention, even from the beginning. Later on, with the help of the European partners, we organized our objectives. And I want to underline that the main objectives, since it was and it is a best practice exchange, was to find ways of cooperation, ways of communication, to develop tools for screening, to develop educational materials, to educate and offer counseling and support to the participants, to develop platforms for data collections and data monitoring. And all of these were successfully done. I dare to say so. Then, of course, we had objectives regarding the use of all these instruments and all these materials to perform the screening itself, and then to come back with several counseling and educational activities for the participants. In order to succeed with this, we made a partnership with the University of Medicine and Pharmacy from Cluj-Napoca, Romania, in order to join our efforts for implementation of the screening activities, but also for data gathering, the research part of the project, and also for development and offering counseling and education regarding prevention and management of cardiovascular risk factors. We also had partnership with Public Health Directorate of our county in order to increase their support and also to add value and trust of the people in the program. Based on this, we started the implementation of the screening itself in September. Would not have access to the names and data of the possible participants to invite them. So this partnership was crucial. And we had, even from the beginning, a few general practitioners who accepted to participate within the project and invite people to the screening, and moreover, to organize together with our organization the screening procedure in their offices, because it was no other possibility during the pandemic to organize, screening on larger scales in any locations. There were several precautions measures in place. Everything had to be done individually with a lot of distance and several issues like this. So we started in September 2021. I said it even from the beginning. We were aware that it will be in small steps with few people, but we said we have to start somewhere. And we started, and we continued since then with the help of the general practitioners for recruiting the patients, with the help of several young doctors and PhD students from the University of Medicine and Pharmacy from Cluj-Napoca, Romania, and also, of course, with clear involvement of different members of the non-governmental organization IRPUR Romania. This was important because it allowed us to recruit the people, to perform the screening, to come back with the information, and moreover, to come back with several information, education, and counseling for the people. Because we were aware, even from the beginning of the project, we did not have, like in Italy, the possibility to tell them, go to stop smoking cessation center, go to these nutrition courses, which are for free, go to this obesity management prevention or prevention program, which is for free, offered by the government. So in a way, we had also to sustain, even if on a limited scale, these types of counseling, education, and we were involved in sending personalized letters, several educational materials, and step by step, when the pandemic went a bit down, we also offered more direct counseling face-to-face. So based on this, to conclude, we started even from the beginning with small steps. We succeeded to continue later on. We were always aware that we have to find more ways to engage people, to engage general practitioners to help us, even we did not have so many mechanisms. It was only their own wish and desire to help and to help our project and to help their patients. We tried to, even if there are not many participants included every month, to continue this all the time. Even in March, we still had new people coming on. We still tried to include new general practitioners on board. We tried all the time, besides the numbers, to offer clear information to the participants. And here, I don't know, for people who are not part of the project, I want to tell it was a complex approach. We tried to assess several behavioral risk factors, meaning quite a long questionnaire about smoking, electronic cigarette use, alcohol use, several issues regarding nutrition, physical activity. Then it was a screening for medical biological risk factors, high blood pressure, or dyslipidemia, or high glycemia, and then of course, or high body mass index. So when you combine all of this, it takes time to perform all these tests. It comes then with the fact that we have more data and we can combine all these risk factors. And then, as I said, we had to come also with the education. So it took time. And I hope that besides the numbers, what the patients could benefit from the project and from what we offered was really helpful for them. And most of all, I do hope that the instruments, the educational materials, the networking and the experience will remain and maybe help to other projects. So within the situation, even now, looking back, I could not think to other action plan for our non-governmental organization. Thank you.
Thank you, Lucia. Thank you. Vaiva, so what's your case?
Yeah. If we talk about the main challenges for Lithuania, so for slow screening process and low attendance for patients, so the main problems, as in other countries, it was pandemic situation and of course political situation because of the war. So people in Lithuania are really concerned about the situation in general and about the war. And if we talk about the pandemic, so it was the time that people, they just didn't want to go to the healthcare institutions at all. And we have very low visits in our polyclinic. And also one of the problems was that Young50 project has a particle duplication with Lithuania national prevention program for cardiovascular diseases, in which we involve men from 40 to 55 years old and also women from 50 to 65 years. One more of a problem was the lack of healthcare professionals which would be interested to participate in this project at all, and also low activity of the patient. And when we asked about the reasons, so they mentioned such things like, I don't want to go to a polyclinic at all. I'm not interested in polyclinic. I already take care of my health myself and with my family doctors and some others. And also the immigration took part in this process, because many times when we call to the patients trying to invite them to participate in the Young project, they were just abroad and had no possibility to participate physically in this project. So if we talk what we would do differently in Lithuania, seeking to involve more patients. So firstly, we would like to choose a wider range of the laboratory tests, including such tests like ferritin, vitamin D, iron, or some others. Also, we think it will be very useful to give more benefit to our patients after our healthcare professional identifies the problem, so he could refer this patient to some other healthcare specialists like dietologists, psychologists, or family doctors. And also, in this case, we think that active dissemination of information between the healthcare professionals and also patients will work in this case always. Thank you.
Thank you, Mayra. So in both cases, they have said that they missed somehow the presence of the Ministry of Health, but that's the other way around in Luxembourg, because they were really present.
I can feel the pressure.
Yeah.
First of all, that's one thing to know about Luxembourg. So we have the Ministry of Health, and we have also the Directorate of Health, which is part of the ministry. And I'm part of the Directorate of Health. So finally, the main challenge for us was to start the project because all the activities have been shut down during the COVID-19 crisis. And after that, we had to finally manage the priorities after that. But the chance we have, and we will have is that the Young50 project is part of a national plan for cardiovascular disease. So we knew at that time that if we are not able to launch a project during the period, we will do it after that. So that was clear for us, you know, with the European project budget or without. Because finally we have the chance to be under the umbrella of the Ministry of Health, and we have the chance to have the budget for it. But of course, for our management, it was one of the priorities to start at least a project and to identify what works and what doesn't work. To be clear, it was a question of time, but finally we hadn't enough people to do it. So the second priority was to find a partner. So Luxembourg is quite a small country. So we have the network for it. And I think that people in Luxembourg know each other. So we contacted the Luxembourg Institute of Health and asked them, can you do that project with us and for us? Do you have the people that can be involved in that project? So that's why we had the opportunity to settle the collaboration and to launch a project in 2021 finally. And so we had to speed up at that time. And finally, we decided to reduce, I will say, the number of people that we would like to include in the project. And as I said, to identify what should be done quickly and what we will do in the future. So the national plan will be finally launched normally in September this year. So that's why it was important for us to launch the Young50 project at that time to identify what missing. So for example, the range of ages will be extended in the next phase. But we know that we have a meeting next week at the ministry to see, okay, what will be the Young50 phase 2 in Luxembourg. And I think I will give the microphone to Marie to explain what we have been able to do and what we will do in the future with them.
Thank you, Fabrice. Okay, yes, so as you said, so we have this top-down model in Luxembourg, but also I think we also from the beginning, we use also like local resources because as Lucia said, so you screen people and then you have to send them to existing programs. So one part of the job we did before doing the screening was to collect all the information of what is already existing. So maybe not like a strict top-down model, I think, in Luxembourg. And also, one also of the first thing was to involve GPs because we knew we were going to recruit people from the GP. So we went to the medical organization, and also we had the chance to have a cardiologist involved from the beginning, who is also involved in the national plan. So you also know the leaders and that you need to have in your team to do this kind of program. So I hope we had this top-down model, but we also include all the local program. And yes, we began a bit late compared to the two other countries. So, but we got some GPs involved, and of course, it was a challenge to recruit patients, but also to recruit GPs, because they were also really busy with the COVID-19 crisis. So it was also a challenge to ask them to do, once again, new things. But I spoke to all of them, and I can say they are all really happy to have this kind of prevention program, and they know the importance of it. And it's really a chance for them to have this particular moment to talk about prevention, and only prevention, during a consultation with the patient.
I will resume the situation, that I think that the role of the ministry and or the director of health is to initiate and to coordinate. But it's very important. That's why sometimes the top-down approach or the bottom-up approach, I don't like really this term. It's because finally it's a collaboration. So as I said, the Ministry of Health should initiate, collaborate, see if it will be a priority for the country in the future. But after that, you have to identify all the stakeholders that should be involved in the process, and you have to work as a team. Because if you don't have the GPs, if you don't have the network, if you don't have the infrastructures, if you don't have the budget, sometimes it won't work. That you can contact all the people you want, you can contact all the participants, include all the patients. If you don't have all the people together working as a team, finally it won't work. And you need specialists from almost every field. So that's why you have to put all the people, and you have to convince them that it's useful for them, for the country. So that's why our next step is probably to put that as a national program, as a national screening. But once again, if during a pilot phase you cannot convince all the stakeholders, you won't be able to move to the next phase and to have it as a national program. So that way, it was important for us to discuss with them to be sure that, okay, does it work? What should we change in the next phase, as I said previously? And so that's why we will change, I will say, our approach, the fact to include the participants, the age, because finally it will work in the future if we do that. So we are still convinced by that, And the availabilities of I will say of the GPs, and I would say the inclusion of the participants are the main challenges also in Luxembourg. That we discussed with people that said, okay, once again they will contact us, they will ask us questions. Why? That's so you have to convince them that they will participate to their health and to their future, or if it's not for them, it will be for their children. That's sometimes a discussion we have to. And maybe you can say a word about the workshops, that finally something that will be important in the future.
Yes, so that's also something. Sometimes you read that top-down model, you cannot be really innovative, but I think we took the chance of the Young50 program to create workshop. So a bit, I mean, it's the goal of the project, but in the same idea of what is happening in Italy, I think they are doing also workshops with patients. So now we created a workshop for the patients who are in the risk category with like life habits to change. So with a physical activity expert, with a dietitian, with a GP who is also really into nutrition and physical activity, and also a cardiologist. So we are doing this workshop next month. And so we are inviting people, and it's also part of our pilot phase, and it's really important to know if people will come or not, and if not, we will learn from this. And also, but I think it's part of the European project. Each time we have this satisfaction questionnaire, which will also help us for the GPs, for the participant, and for the professional who will take part in the workshops.
Thank you. Thank you very much. So hearing from Fabrice and Marie, it seems that, and also from you, that synergies, networking, collaboration between different actors in the field is really crucial. In your case, you, till now, you didn't have maybe the support from the ministry. How do you envision to try to engage them in this process after, beyond Young50? Because Baiba, you have said that there is a national program.
Yes.
How can you somehow complement or make synergies between?
If we talk about our stakeholders and successful project implementation, so the most important thing for us, it seems to make the Ministry of Health as this project coordinator, the main coordinator. In this case, we can what? First, we can involve all the healthcare institutions, or maybe more of them, to participate in this project. This way, we will have more healthcare professionals also. So the second thing, it will be to involve also the public bureaus of health, which can be leaders for the consulting patient for the health lifestyles. And also we would suggest to involve the universities of the medical from different sides as the main trainees for the practitioners. And the most important thing, as you said, the coordination between all these institutions, as I mentioned, and also very close collaboration between them inside. So, and so that I think the most important things are, and also with all of them must go the finances. So that's my opinion.
Thank you, Baiba. And Lucia, in your case, how would you manage to try to convince maybe the health authorities to try to push forward the Young50 project or this screening program?
If we look to what we said, different organizations from different countries, indeed, we all underline how important it is to have a longer-term strategy and a good cooperation. The Ministry of Health said that it's difficult to engage stakeholders. We, as a non-governmental organization, say it's difficult to have our voice heard by the Ministry of Health. We just saw a very comprehensive and ambitious joint actions at European level. I'm very glad I saw Romania on the list. I do hope that this commitment of governmental organizations, because joint actions is very much about government and the public policy of the country, will continue this trend. And from our perspective, as I also mentioned before, I want to underline once again that, of course, besides the importance of the Ministry of Health, engagement and leadership at different levels is important. And we are more than happy to contribute in different moments, in different ways, with our expertise, with our experience, with our time. And based on the cooperation we had at local level for Young50 project, I want to underline briefly the roles a non-governmental organization or a university can play. A non-governmental organization, indeed, flexible. You know, it's not necessary to wait for a lot of improvements. Of course, a lot of ethical and scientific aspects should be followed, but has a better flexibility, is very much involved in the community, so has the capacity to help and to participate, and could contribute actively in terms of performing activities, but also in terms of expertise and building strategies and mechanisms. On the other side, we saw also with the joint action how important is the research, the implementation research, data gathering, communication of this data to the scientific public, but also to the community, to the stakeholders, which means several times to the same data, you need different approaches and different ways of presenting the data. And the university is always a university from any country, a good university from any country is always a very good actor on this. And even in our project involving the university and involving PhD students and having a clear commitment in both ways. They will participate in our screening and data gathering, and afterwards they have the possibility to use the data for dissemination in scientific journals, was very important. So it's already sort of say, maybe a small example at local level, but if all the partners agree, we can build on this. And I do hope that this project and other European projects would be included in a way in next proposals or projects or joint actions which are in place or will be in place.
Thank you. Just before closing, because I think that we are, yeah, just few words, one advice or recommendation that you would just share with future implementers of this kind of screening programs. 1, 2, 3 words. A bit more if you want, but brief. It's just one message. I mean, take home message. Yeah, please. Lucia, if you have your message clear.
Strong cooperation and involve partners based on win-win principle. It's not only funding. Some people might have benefits in terms of data, in terms of recognition, in terms of using their own materials. So strong cooperation and win-win approach.
Thank you.
Fully agree, and do not underestimate GDPR also and the regulation, because at the national level we had to go through different committees and convince a number of stakeholders and regulation teams. So no, it was it's probably something you should prepare in advance before the submission of the project.
Vaiva, your last words,
Yes,
please.
we are very grateful that the Ministry of Health is really interested and feels very positive about this project. So we know that they already have some important meetings and active discussions about how to take the best practice from Young50 project and to integrate it into our international program that I already named. And one more plans of them that we already heard. So they are planning to find the IT solution, how to record all the patient data selected by Young50 project and to put it in our national e-health system. So we think it will not take long. Thank you.
Fantastic. Thank you very much for all of you. I don't think that we have time for any questions, if any, in the audience. Okay, so thank you very much for everything.
I'll just ask you 10 minutes of patience before we break. I'm really sorry we are running a little late, but my job is to, in a brief way, say what we have learned, the lessons learned from our project. It was a mission impossible, and you can listen to my I feel very much like Tom Cruise. Just to get a short, I just wanted you to like feel how it feels like to be a project coordinator in such hard times. Before I go on, can I ask all of you to stand up? Because we've been sitting down for a long time. Just start doing a little bit. Yeah, move your legs. Okay, great. 2, 3 squats. Wonderful. Deep breathing. Now you may sit down. So you'll be a little more attentive to me. Thank you. So this was our project. As you can see, we started May 2019. And as you heard before, we had our kickoff meeting in June in Luxembourg. Our intention was to do a feasibility analysis June 2019, immediately after our kickoff, adapt the project October, start screening from April 2020 in the different countries, collect data, develop an app, do a follow-up, analyze the data, and have our final event April 2022. You just realize we are actually in April, but it's not 2022, but it's 2023. So what happened? We had started, actually the 3 steps that we decided to do, the feasibility with the kickoff and adaptation we did do in time, but then we were supposed to start in April 2020. You see that in March we had general lockdown for the pandemic and 4 waves of COVID, as you may all remember. So we immediately understood that we needed to have an amendment and ask for some more time so that we could do our screening. And we decided to start the screening in September 2021. And as you heard, we actually did start. And our plan was to collect data, develop the app, follow up, and have our final event April 2023 as now. But this was not enough, because what happened when we started our data collection, as you heard from the round table with our partners, there was still the COVID going on. We had the vaccination campaign, and then we also had the war, which is not still over. And as you know, before there was a huge displacement of people who went to both Lithuania and also to Romania. So it did have some impact also on our, and as I remember, Lithuania said the first things that we heard from them was that the people who they invited were not at all interested because they were so much more aware of what was happening in the neighboring countries. So this, of course, brought us some more problems. But this was not enough, because what happened during all this time, apart from the pandemic and the vaccination and the war, we also had different situations. For example, we had Shafaya, which became Hadea, and they decided to move from Luxembourg to Brussels. So actually, when we were starting, we said, okay, the amendment has to be done very fast because otherwise things may not move. That wasn't enough, because I don't know how many European projects have 3 project officers in the arc of 3 years. It is something common, but it's something that can disturb, because you have to get to know the new project officer and then have communication with them, get to know them, give all the information. And in the end, actually, we have Hugo, because he came really in the final part of the project. That was something that also sort of, alarms came out for us, everyone. And then, not enough, When we just started and we were about to move in Luxembourg, and as we heard, we had the Ministry of Health, so they were quite strong. They were starting strong, but the project principal investigator decided to leave. And it took the Ministry of Health quite a long time to get a new principal investigator, because they also had the pandemic and they also had their problems with the vaccination campaign or whatever. And we also had changes in our other partner countries. For example, Lithuania had in the final stages of their project, of our project, the principal investigators, not one, both moved to different projects. So now we have, fortunately, we had some Viva and also a health worker who had followed right from the start. Today, for example, she's present also among us. And so there were different changes also in our project pilot countries. The only one who remained the same, Romania, I must say. One at NGO, but they managed to remain. They were the same people who started. So now, before we go on, I would like to say, what lessons did we learn from this project? It was supposed to be, 3-year project. It became 4-year project. And what I have learned, at least my team, and I must say, thank you very much to my team at our local health authority. I have only 2 of my team members today, Carlo Giordani and Joanne, who is our project manager. They were really very supportive to us, and we have created a small team who are working at the coordination level. But what I've learned is that if we have to do a European project, we should have too few partners, not too many. I'm not sure about the joint action with 27 countries. That's a big challenge, but we had only 3 pilot countries, which means that if you have one pilot country who is in trouble, it means, it can sort of slow down the whole process. And we did have that, but for the fact, as we heard from Luxembourg, they started late. Then we had the shift of principal investigators. And another lesson I learned is that each partner countries, each pilot site should have dedicated project manager to follow through, because it's very difficult for people who have already full-time jobs to, continue and implement a project in their countries. So to be able to do that, you need some dedicated people. Another thing that we learned, the coordinating team should not have too many work packages. Actually, we were supposed to have 2 other partners who did not join in the final stages of our project. So what happened was, in the end, the coordination team had to take in some more work than what we had decided. And that can be quite challenging. But we also had the good luck, so to say, the good fortune to have other people who helped us. We did have people from the university who helped us in our evaluation process, for example, and also for one of the work packages, we gave the work to somebody else. Another thing that we learned is there are a lot of publications which says that to transfer something, a bit best practice or whatever, takes time. It can take up to 17 years. And we actually have one recent publication, actually this month it came out at JAMA, which says, again, the same thing, that it's not so easy to transfer best practices. It can take time. So, that means that actually we can consider ourselves, if we manage in the 4-year span to manage to start to implement the best practice, is not bad. The other lessons that we learned also is that even if you have very good coordinating team, it's not enough. You have to have dedicated partners, highly motivated. So you can be a good coach, but you also need good people who are good players. We did have few, but at least we managed. Our players did play full out. And the important thing is also to be able to transfer a best practice. You need to set goals. I saw joint Jakarta, they're not there, they said very high goals, they said. And it's good to have high goals, or even not so high, but at least once you have set it, we have to keep it, because it's difficult otherwise, to be very, how can we say, focused on what we want to reach. And I must say that we had, yes, 3 pilot partners, but they were 3 very different ones. And as you heard from our roundtable, we had the Ministry of Health, we had an NGO, and we had a polyclinic. So these are 3 different settings. And we found also that even though there were 3 different settings, Polyclinica is used to work with patients, NGOs are used to work with population and with stakeholders. Ministry of Health normally has top-down approach, but we have learned that we have all learned lessons, which are the positive takeaways from each of our experiences, which we already discussed in our table. And also we saw that actually it is possible. And even though there were 3 different sites, they did all 3 countries, even though sometimes with delay, managed to start the screening process, collect some data, maybe not as much as we wanted to. And we do have this data that we can analyze and see what is happening. Certainly, the long amendment periods is also another lesson we learned. We have to take into consideration that if we want to have amendments, it's better not to have them. But then when things outside external factors hit you and we need to ask them, we have to understand that it can take time, which means that, you know, we cannot have, like when we couldn't decide whether it was going to be postponed, not postponed, extended, you know, we have to be careful when we extend that we actually manage to get the extension. And the challenges also in the recruitment that we got, because as we heard before, because of the people we changed, because of the partners we changed, because for example, in Romania, you had completely different partners who were supposed to work in the beginning. Then since the pandemic hit us, they decided to change different people who were going to recruit. You were not going to use GPs, but then you use GPs. And then in Lithuania, you had people who were worried to come to the clinic. So we need also to think about who are our participants in our thing. And we also heard differently that we need to have, Lucia said that in Romania, that we need tailored communication approach. We cannot use the same messages for our different people, even though they were all 50-year-olds, but they are come from different places. People who recruit them are different also, and the language that we are used to use are different. So we need to also learn, even the people, the health workers who are recruiting the people have to be very good at communicating and understand the importance of how you communicate. It's not enough just to shout, that doesn't help. But it could work, and it has actually worked. So I'm very glad to say that even though we have limited data, the 3 countries managed to do the pilot. We have collected some data. And if we take care of all the items that we said here, and remember, it can take, don't be discouraged, it can take 17 years before you can transfer the best practice, but it can be done and it could work as I don't know how many of you are familiar with this. Is taken from Frankenstein Jr. So thank you very much for your attention. If there are any questions, we are happy to take. Also to our partners, because I know that there are some people who are not aware of this project. So if you need any further information, we are happy to give you. Otherwise, we'll have a short break and then we'll meet for our final roundtable session. Thank you very much. Come back. I was trying to find you at the ESC. Yes, but I couldn't. Yeah, and then I'm glad. Thank you for coming. Yeah.
Solo quello.
Just checking to make sure you can hear me.
Can you hear us?
And I'm trying to see if I can hear you just for a minute. Okay, can you say something, please? Okay, I can hear now. I can.
Hello? Yeah. Right now.
Hello? You wanted to say something? Please go ahead.
Oh no, I was just making sure that I could be heard loud and clear.
Yeah, you can. Okay, great.
Great.
Thank
And
you.
I'm going to try and stay for the duration, but I also have to catch a train to Luxembourg this evening.
Okay. Can you stay on for another half an hour at least?
Yeah.
Or 40 minutes?
Yeah.
Okay.
I'm going to really, because I'm more or less packed, so I should be okay.
Okay.
You will be first to talk
Okay.
maybe in the round table so that if you have problems, you can leave. Okay?
Okay, in which case, could you ask me a couple of really interesting questions so that I can actually reply to them? Because we know where we are today.
That's what we expect from you. Thanks a lot.
Okay, wonderful. Thank you.
Okay, before we start the round table, I just wanted to take a couple of minutes, maybe, just to show you, what has happened. It's not on the list on the program, but we just decided that we should at least show you something about the sustainability of our project. Nicola. Thank you very much. I just wanted to, since the roundtable is going to be on the sustainability, height on the top of you. Thank you. I just wanted to say that actually, you heard that our CARDIO50 project was taken as the best practice. So during this phase of our project, Young50, we asked the University of Padua, the Department of Statistics, to analyze some data for us of our CARDIO50 project from 2014 to 2019, just to see the effect, how effective it had been, the screening program. So I just wanted to give you a little bit of feedback just to say that what we found. We analyzed the data from T0, which means from the start, and to T1 when we had the follow-up. So as you can see, as Lucia told you, what we do is we have a long questionnaire. It takes us almost 20 to half an hour, 20 to 30 minutes to screen the population who are invited. They were a 50-year-old population, and they are asked their lifestyles questions, their eating habits, whatever, and we classify them in 5 groups, A, B, C, D, and C1. But the interesting groups are A, which have the healthy lifestyles and no medical parameters that are out of, let's say, not in good condition. And B are the ones who have problems with their lifestyles. And C are normally people who already are under medication or have some problems with medical problems like hyperglycemia, hypercholesterolemia, or high blood pressure, or obesity. So we, as you can see, the first things that we found out at T0 is that there's a big difference between males and females, same age, but women have better lifestyles, it seems, than males. And they also have less problems with their blood pressure and blood sugar and cholesterol. We also saw that people, this is just to confirm the data that we already see, that who are the people who are more instructed, like who have a degree or have higher education, are the ones who have better health. And this just goes to show that, you know, the question of inequity is normally also related to the education levels of the people who can take care of their own health, and also the people who have, for example, participated more in this kind of programs, screening programs, were always the higher educated person. And we also see that, for example, at T0, we also had, we saw that there were people, blue is males and the pink, supposed to be pink, was females. Those who have, women have less problems with with their eating habits, the use of alcohol, physical activity, sedentary habits, and smoking was less in women. The only difference, let's say the higher rate of women, were the waistlines. The women have higher waistlines. Although eating better, maybe they eat more sugar, could be. The participant rates also, as you can see, we had, for example, 60% of participants, and at follow-up we had like 51% of people who were invited. And the success rate of our, the effectiveness of our program, as you can see in the years, people who had problems with the eating habits got better, like 50%. Alcohol also reduction. They also, the physical activity also were improved. We had less improvement as far as smoking was concerned for the BMI and also for the waistline or the abdominal circumference. And the last slide that I wanted to show you was that we also carried out an analysis on the use of medication, like all these people in these years of surveillance that we had, you know, from 2014 to 19, when they came back for their, we used the database that we have at the regional level, and we saw that the class A persons use less medication in the following years than class B. Class B were the ones who had problems with their lifestyles. And class B had, compared to the group A, 52% more use of medication. Thank you very much, just to show a little bit. And now you can start with your roundtable. Thank you very much, Giovanni.
Thanks, Elizabeth.
And also to you.
So we will now introduce the roundtable with the expert that we will introduce you in a couple of minutes. Anyway, we are Giovanni Viganò and Paola Ziabutera from Synergia. We are in charge of the long-term sustainability analysis and evaluation of the Young50 model. And today we will discuss with our international experts the sustainability, the long-term sustainability and policy integration of the Cardio50 model. Before we start with the presentation and the speech of the experts, Paola will now show you a sort of summary of the main things that have been already actually presented by the Young50 partners during the presentation. So, Paola, I think we are ready, and the floor is yours.
Thank you, Giovanni, and thank you everyone for having us today in this very interesting conference with very important inputs from all of you. Before introducing our roundtable, as Giovanni said, I briefly want to recap what has been done in our work of evaluation, the methodology and the results that we already have, and also the work, of course, that is still going on even today. So the work carried out by Synergia was developed along 2 lines of intervention: a vertical evaluation of the sustainability and integrability of Cardio50 model within the policy system of partner countries, so Lithuania, Romania, and Luxembourg. And of course, this line of intervention directly involved the partners of the project with the realization of an online survey and direct interviews with key local actors at the national and local level. Then an horizontal and transversal evaluation of the potential transferability of the model at the EU level that is going to take place even today with this roundtable. Now I'm going to present very briefly the results of our vertical analysis because we have already seen some of them in the very precious contributions of the partners before. We decided to insert in this section also Italy. Although Italy is not a site for the pilot, we thought that it would be interesting to also leave Italy for the comparison. We asked whether the project introduced any innovation in the national context, and in Italy the main innovation was through the development of an app. The most important thing was underlined during an interview was that partnerships have been created with various organizations, and that also connection with existing screening programs at national and local level were created. As regards the sustainability and the future plans, Veneto region has allocated already funds to ensure the sustainability, and the project is considered replicable at both regional and national levels. However, it is important to underline that additional funding are necessary to continue and to ensure sustainability. For the future development plans, Young50 project will extend its interventions to all local health authorities in all the districts of the Veneto region. As regards Luxembourg, we already listened to the contribution of the representative of the partner. As regards the implementation by itself for the screening model, the project did not introduce any innovation. However, as also it was underlined, a main innovation was where the workshop with the patients. As regards the partnership, it's important to highlight, of course, the connection with the existing national screening programs and the important partnership, the deeply rooted partnership with the Luxembourg Institutes of Health. As regards the sustainability and the future plans, the Ministry of Health has allocated part of the budget to fund it, but of course other funds are required and probably are likely to be added, but this depends on the political willpower. The future plans see a project that has already transitioned from a pilot program to a nationwide systematic screening program. So it's a very good result in Luxembourg. As regard Romania, the project, as been already mentioned, has introduced innovation with educational paths, screening cardiovascular risk factors among age groups that are not usually targeted by the national screening program. The important partnership have been highlighted, the one with the University of Medicine and Pharmacy and the Public Health Directorate of Cluj County. There is no evidence, however, that the project will continue after the project life, and there is no funding program in place to ensure the sustainability. However, the good practices of the project have been, there is the willingness to transpose them at the national level, especially with the plan to develop a national platform for data registration and risk classification, improve tools and protocols for data collection, and also proliferate and disseminate educational materials for healthy lifestyle. In Lithuania, even in Lithuania, the project did not introduce any innovation with respect with the national screening program, but the project has allowed to activate important synergies with another project, the European project Physical Activity. It is likely that part of the project will be implemented in the national screening program and in small municipalities. There is no official decision yet, but discussion have been done with the Ministry of Health to incorporate project good practices into an existing national program. As regards the strengths and the weaknesses of the program, there has been a common acknowledgement, of course, that the Young50 has increased the awareness of the risk of cardiovascular disease through information activities, education, and counseling. All the countries have highlighted how the good collaboration between partners has been a fundamental aspect, as well as in some countries, especially as in Lithuania, the flexibility in the implementation, considering the presence of different national contexts. And Italy and Luxembourg have also mentioned that working with other organizations and building a network has been an added value for them to give also specific assistance to patients, for example, to refer them to smoking support programs. As regards the weaknesses, in all the countries, the number of human resources, especially GPs, was lower than the real need. And also the lack of the necessary financial resources was mentioned by some countries. Of course, as we have already mentioned a lot today, the spread of COVID-19 has been a common challenge for all the countries too. The lockdown, in fact, slowed down the project activities, and even after the emergency period, it was very difficult to intercept patients for screening because they were often frail patients who feared the contagion. So, as Giovanni Nicoletti said before, the key for sustainability is always to have national inputs and expertise. So, even today, we are trying to do that and to realize this objective. We organize this roundtable. The goal of today is to understand how to integrate the model into regional and national policy and planning of other European member states, so at the EU level. And the main idea is to collect the opinion of our experts on the main obstacles and the critical and priority elements that could maximize the transferability of the project, or a project like Young50. So I will give the word to Giovanni Vigano.
And thanks a lot, Paola, for your very useful summary of the results in all partner countries. And now it's your turn, experts. Today, we have 5 experts that actually joined the roundtable. We are here with Paul Dendal from the European Association of Preventive Cardiology, Michele Calabro from Euriga, Anne-Marie Wesley from UPAP, Jacqueline Bowman-Busato, who is actually joining with us online from the European Association for the Study of Obesity, and then Cornel Radu from the European Network for Smoking Prevention. So we have 5 experts that actually can provide also a different point of view on the possibilities of policy integration and long-term sustainability of a prevention project, of a prevention program like the one developed by Young50. So we had a secret, but actually, Jacqueline, you spoiled the secret that we have already sent the question last week to all the experts, so they are already prepared. Anyway, I will actually tell our secret. I will tell our question to the audience that actually is not aware of the question that you are going to respond to. So we have seen the experience and efforts of the Young50 partners to integrate the Cardio50 model in their countries from a policy and programmatic point of view, and to make it sustainable on a long term, which is the greatest challenge that they are facing. And during the presentation of the first part of the meeting, we have heard from representatives of international and governmental organizations what are the critical and key factors that can maximize the impact and sustainability of a prevention program like Cardio50 in the European member states. So according to your experience and your vision as experts and representative of international networks, initiatives, and organizations, what are the main challenges or barriers that could impact on the policy integration and transferability at the EU level of a model like Young50 for prevention of cardiovascular diseases? So I kindly ask you to stay in 10 minutes because time is running, as you know. We will start from Jacqueline Bowman-Busato. So the floor is yours. If you can stay in 10 minutes, we are so grateful. Thanks.
Okay, thank you so much for giving me the floor first. I think that what I have to say, yes, will be slightly different to everybody else. I'm pretty certain about that. I'm going to try and keep way below the 10 minutes because I think that this topic deserves a lot more conversation and, more importantly, actually moving towards some practical solutions. So if I had to summarize and say, what would it take? 2 things: money, and I'm going to come back to that. So resilience, sustainability, financial and resource sustainability. And actually, even before that, I think it's important to understand that one person's prevention and primary prevention is somebody else's acute treatment and long-term management. So I'm going to take the second point first, if I may. So as I was introduced as being head of policy at the European Association for the Study of Obesity, so we represent federations in 36 countries across WHO Europe, ranging from public health professionals through to researchers, investigators, clinicians for all of the allied professions, and also students. We're very active in a number of EU projects, as well as clearly policy outreach, and work within a number of both national as well as supranational, so EU and above level coalitions. Why do I bring that up? Well, actually, it's because one of the major barriers, and I know, Michele, we work with you very closely as well from a Eureka perspective, and others, I'm sure, in the audience. But one of the big barriers that we've seen and continue to face is that, dare I say it, there is way too much siloed thinking. Now, in terms of embedding models such as the Cardio50, which is fantastic for early diagnosis and screening, and actually having screening programs based on clear predictors. What I haven't heard mentioned to date is that by treating obesity, and I'm not talking about waistlines and all those sorts of things which were mentioned, which wasn't actually talking about obesity as a disease, but was talking about general health promotion across the dietary related diseases, so cardiovascular, by treating 35%, by treating obesity and the disease, so the abnormally functioning, the malfunctioning adipose tissue, so your largest organ, by acutely treating that to get it under management, we will prevent 35% of cardiovascular disease. So, and 20% of preventable adult cancers, and 80% of type 2 diabetes, and a whole plethora of other medical complications. So in the case of cardiovascular risk, what we're looking at isn't the usual, well, let's have general population level health promotion in general. Actually, we need to focus in on that 60% as well, who's already living with pre-obesity, brackets currently known as overweight, and or already fully fledged obesity. And what we need to be able to do, certainly from an EASO perspective, is to look a bit more upstream and not say, okay, we're only going to screen for cardiovascular, when quite frankly, it's a bit too late. Now, how do you actually build those ambitions into a policy environment? And more to the point, hence my first point, how do you pay for it? Yeah, it's very straightforward, because health systems love to talk about, quite rightly, there is no more money. And there isn't, quite frankly. The numbers are astronomical. And just last week at the European Parliament, we actually did the launch of a study that we've been working on in a multi-stakeholder environment called the cost of inaction of not implementing obesity within the context of the NCD framework, which again is going to be something that I think this particular model that we're discussing today needs to take into account, that every single country, one way or another, has disease management plans, which in the case of cardiovascular and other major policy prioritized NCDs, essentially is based on the chronic care continuum. So early diagnosis and screening, what I would call acute treatment and long-term management, and there are budgets that go with it, reimbursements that go with it, infrastructure that goes with it. For obesity, this has not been the case, even though it's been classified as a disease by WHO since 1948. So we are actually in a situation whereby, in order to get sustainable policy implementation, we focused on health systems resilience, which I would strongly advise is also the case here. Catch it early, you'll save money up front. Also, in our case, we had to focus on what's the cost of inaction. How many more deaths prematurely, independently caused by obesity are there going to be? How many more astronomical rise in cardiovascular disease, in cancer, etc., are there going to be? And actually, which is the next point I come on to, we were able to actually calculate this. We created a model, which we're very happy with, which actually goes outside of the health system. Strongly advise you to start thinking about that as well, in terms of how to leverage this model beyond the usual health actors and say, what is this? How does this relate to broader society in general? That's what we've had to do, because actually when we started counting the costs of inaction to implement obesity under the NCD framework, the numbers they're just astronomical and would use up per person per year more than the entire healthcare budget. So not to scare people, because those are really large numbers, you then have to sit there and say, well, what's missing? What are the gaps in order to make this something that, territorial, national authorities will actually take up? So that's when you start thinking about, rationalization of resources. And to be honest, that's where models which allow you to have targeted screening and early diagnosis and screening programs, which is what we saw was the biggest gap in terms of policy related for obesity health outcomes. That's actually where the gap lay. So to come back to some, advice, as it were, or guidance in this environment, I think it's really important that you're able to actually make that bridge between, the scientific inquiry and actually what are you trying to really achieve in society? Because at the end of the day, when policies are adopted and implemented, it's to make a concrete change. So what are you doing that will actually help European competitiveness, healthy workforce, more productive workforce, helping employers, because actually they're going to be some of the people that have to pay for this as well. So things like that, to actually take it out and find a win-win for the various stakeholders who can actually help pay for this. Because, and I think someone's looking at their watch, so I'm going to round up any second now, because what will happen is that if you, and final point for food for thought, if you create a viable early diagnosis and screening program, basically you will be opening Pandora's box. So you have to find a way to say, okay, this is feasible from a resource allocation perspective, and see how it integrates with other major chronic diseases. And in our case for obesity, that's an easy argument for us. But I think you need to see, with the evidence that you have from this EU project, how can you also make that work for you? So money and resources, and think out of the box. Thank you.
Thank you very much, Jacqueline, for your very clear and pragmatic, I would say, point of view and suggestion. Especially, I would like to highlight your one of your final messages on the required bridge between science and society, which I believe is quite a very important point. And for this, I forgive you for spoiling our secret, okay? Thanks a lot. I don't know if you can stay.
Yeah, I can stay for a bit.
Okay, thanks a lot. But now we have to move rapidly to our second expert. It's your turn, Paul Dendal from the European Association of Preventive Cardiology. Same question, same rules, 10 minutes if you can stay in it. Okay, thanks.
I will try to be even briefer than the previous speaker, because I think you have already been sitting here for half day. As past president of the European Association of Preventive Cardiology, I'm obviously very much interested in prevention, and I would like to start off with the prevention paradox that you may know. The idea is that when I'm sitting as a cardiologist in front of you as a patient, I can have a very major impact on a very minor part of the population. Whereas if we take public health measures or well, general measures, let's say reducing pollution by so many ppm or reducing smoking by 5%, this may have an enormous impact. It's a small impact per person, but a very large impact if you look at big numbers. And so even if sometimes these kind of projects seem disappointing because you don't reach everybody, if you can have a small impact in a sufficiently large number of patients, then this really helps in combating the problem. And that's why the ESC is more and more involved in trying to bring together all the stakeholders, because it's obviously not an NGO or one Ministry of Health, but it's everybody together that needs to work in a coordinated way. And for that, at the EU level, we're striving for an EU cardiovascular health plan, and we would like to have each country to have a national cardiovascular health plan so that we bring everything together. Because screening for obesity or for hypercholesterolemia or for hypertension, that's all very good. But of course, treatment is not so easy. Adherence to treatment is not easy, for example. So there are other policies that can play a role. For example, change the impact of pollution, go more towards healthy mobility. By that way, other policies can also have a role in reducing cardiovascular disease. So I think we should look at it more holistic, and a screening program such as Young50 can have a role in that, but screening and not doing anything, of course, doesn't help. So that's one thought I had. I've taken a few more notes here. One thing I think to not to strain too much the workforce that is needed for these kind of screenings is use already existing screening moments. For example, in most countries, we have screenings when you start working in a company, or we have yearly screenings for this or for that. Well, I'm pleading, and I've tried to convince our occupational medicine specialists that this is a fantastic opportunity to do a few measures. When you have to check for lead poisoning in people working with lead, for example, then why not in the meantime check for their weight, their blood pressure, eventually even cholesterol. We are doing that in our hospital now. And so that way, without any extra cost or with little extra cost, you can reach the same results as with programs such as Young50. So I would suggest try to incorporate Young50 into already existing screening programs so that you don't need a completely standalone organization. And then digital tools, I know it's not easy, and I'm also involved in an Horizons project where we do program a prevention app. Programming something like that is a very hard work, and having it accepted. But I think digital tools will help us in the future. I'm really convinced. It won't cure every problem, but I think going towards digital tools for detecting high-risk patients and doing something about it in the meantime without straining again our healthcare workforce, I think that's something to take with us. And then, of course, for the near future, better screening tools. Genetics, for example, is now not yet in current use, but at a recent conference of the European Society of Cardiology, we saw the promise of the genetic passport, where you would once in your lifetime have a genetic profiling, and then you would know already which of these 50+ people would need more attention for cardiovascular disease and which others could need more attention for obesity or cancer or others. So I think new tools are becoming available very soon, and digital and screening tools. But in the end, it will have to be a collaborative effort, and everything we do, even small impacts on large number of people, will make a difference.
Thanks a lot, Paul. 3 important things on my notes here after your presentation. The holistic approach, so important. The other message you stated, we don't need to reinvent the wheel most of the times. We need to start and capitalize what's existing and works and make them work together and integrate them. And Young50 is one of these bricks that can be merged and integrated with other programs that are already existing, and then maximize the potential of the digital tools that we have and also the screening innovations. Thanks a lot for your message. But now we move rapidly to our third expert. I think it's your turn, Anne-Marie. Anne-Marie Wesley from UPAP. So 10 minutes.
I'm actually from the Public Health Agency of
Oh,
Sweden, which is quite an important note on what I'm about to say. But I am also the project coordinator for the other sister project, the Young50.
Thanks.
And I can talk about the experience from trying to transfer the Swedish model of physical activity on prescription to 8 other countries within the European Union. And the lessons learned from that project is that it calls for a champion when you do this. You need dedicated people. And it also is that it's much easier in a country, especially since we were doing this during the pandemic, where they have already started. So this type of actions actually enforces the work that has already been initiated. But if I would talk about on a European level and what it demands, some of the other lessons learned are that considering the heavy burden in the healthcare systems, we need on a policy level or an organizational level, allocate time for these type of actions. And that is something that we have learned in the the work with physical activity on prescription, that the screening here, I think you said it took about 20 minutes or something. And the doctors in Sweden, I think they have about 6 or 7 minutes per patient in the healthcare clinics. It's not feasible to have this type of screening with the amount of work that they already need to do. And then it's much quicker to prescribe a medication for high blood pressure or something like that. So we need to also make an organization where this type of screening can fit. So it's not an extra burden for the primary health clinics. What is really an experience from Sweden as well, since we didn't do the implementation, we've been working with the Swedish method for physical activity on prescription for about 12 years now. We're still not, it's still not fully implemented, even though we do have the national guidelines, we do have the education, we do have the prescription, we have everything available, but since that the medical doctors at the primary clinics do not believe in the efficiency, they are not using this method. So it's also, as you were saying, we need to make the physicians believe that this type of screening actually makes a difference, because otherwise they're not going to promote it. So that's another point, an important point. But what I would like to say that since we were not implementing the method in Sweden, but we still did the feasibility study. So we did a mapping of what does it look like? How much are the clinics using this type of method? And actually that method, that report from the European project have now developed into 3 governmental assignments. So the government has pinpointed this method even more, and from our agency, I think we have received 2 governmental assignments to reinforce the monitoring and follow-up, so we get the data. How are we using the method? And I think that is also on a policy level, you have to be able to show on the efficiency and that they are actually using the method. I think I will stop there, but as I said, we need to allocate time, and we need to, all these type of actions need to have the amount of resources so we actually can do it.
Thanks a lot. 3 new things on my notes after your presentation. Thanks for bringing the time variable in. These kind of processes require times. We need to keep it in mind. Also when we develop projects or programs in general and policies. And then the need for an effective organization, that's so important. And finally, that we need to convince physicians on the effectiveness of these tools. And it's up to us, all of us, to provide that evidence that can be, that can convince people that these are important tools. Otherwise, it's time lost and money lost most of the times. So we have the final intervention of our 2 experts. It's quite challenging for you now to provide new things, because the other experts actually have already done a very rich, presentation. So we will start from Michele Calabrò from Uriga. I can give you my mic if you want. Yeah, no.
Too many. Okay, thanks a lot for giving me the word. It's very hard to follow up on this, but I'll actually try maybe to bring in a slightly different perspective. So Euriga is a European network of regional and local health authorities, and we're of course also very happy to be here. Giovanni Veneto is one of our members, and by the way, it's great to see such successful project, because I'm involved myself in a project that got heavily impacted by the pandemic, so I know how complex it is to manage this. But I mean, the results are really interesting. And but building up on these, I think looking back at kind of 3 challenges and 3 positive points also for scaling up, let's say at European level, so beyond like the countries and regions involved. Well, one point, the general challenge, I think it was mentioned in several ways. So the concept of resources, the concept of, we know already how many times in the state of health in the EU and so on, the resources allocated to prevention are simply not enough. So this it's a problem that has been going on for several years. Still a problem in terms of times, in terms of health workforce, in terms of money, simply. But it's not just about the money. Also, it's about like the knowledge on how we can better use it. And it was great to hear how a project such as Young50 and the approach can be fitted into what's happening already to avoid duplication of expenditures, especially in a situation where we know that resources are by default scarce. And that's also a good element to eventually convince other people to adopt such thing. And the second point on the kind of weaknesses, I think it's something that again was mentioned. It's health workforce and how you can best use health workforce that it's already stressed, has a lot of time to dedicate to other tasks. It's complex, as in when it comes to providing digital skills or everything else. Like, how can you make that kind of mindset shift on towards kind of adopting something new? And I think you can do it with partnership, as again it was mentioned. So it's very important. I'll come back to this point in a second. The third big challenge, of course, in scaling up a project like this, seeing from the work that we do and also experiencing working in similar projects, is of course the different approaches that you have across countries, but also within the same countries, especially when we're talking about a heavily regionalized and local health authority-based setup. Clearly, copy-pasting things is never the easiest thing. You need to not only think about where the model could be possible to scale up because there are similarities, there's a similar level of resources and so on. But you also really need to get to this answer, you need to know the other context. And but how you do this? So like, let's say, looking positively at this. So what are the possible solutions? I mean, one solution is connecting with other projects that might have had like similar experiences. I think this is very important. The second point is also connecting to networks such as Eureka, but also networks of physician, networks of patients as well, that can provide a useful sneak peek into what could be the situation in another country, in another regions, because they know there might be already a challenge. The challenge might be there's no political willingness to spend more money in this thing. The challenge might be there's not enough health workforce to deal with it. Or the challenge might be patients or citizens in general do not get the information at the right time, which is very important, of course, for screening, as we know. So a partnership with organizations, they're dealing with the key stakeholders that are needed to make this work. At the same time, understanding that there are different stakeholders needed into making this work. It's not just about the regional authorities, but it's about the regional authorities and its ecosystem around, again, patients, professionals, and so on. I think, interestingly, there is a big project, well, initiative that has just started, which is the Horizon Europe Partnership on Transforming Health and Care Systems across Europe, which is actually a partnership that could bring that connection between different countries or understand, okay, the model that you have developed in XYZ countries could actually work in ABC country. So you avoid basically losing time, which is also a matter of essential scarcity, into trying to copy paste or adapt something in a context where it's not adaptable. Final point, maybe it's of course linked with other platforms. I mean, we had some great examples today. The joint action Cardi mentioned. I think these are the ways where projects such as Young50 can kind of get that scene that is needed to say, hey, you know what, joint action or project, we've been doing this already. This has been working. This has not been working. Let's try to make a good use for it. And one very, very last point, I think also like looking at one of the main strengths of what you achieve is raising awareness on the issue. And raising awareness of the issue is something that is never enough, I think. And I think if I can give like another, small suggestions is, again, in collaboration with regional local health authorities, but also with their networks, try to understand how awareness raising information campaign can really reach as much as the biggest part of the population as possible. Because without that, you can have the best screening system anyway, but if people do not show up to do that, and unless you use solutions where you're already doing screening on other things, you'll never get the results that you want.
And thanks a lot, Michele, first of all, for sharing your experience on another initiative that was affected by pandemic, another mission impossible that at the end of the day was a mission achieved, like a Young50. So thanks for sharing that.
You still need to do the final call.
Okay, but you are in a good position actually to achieve the mission. No, thanks for reminding the importance of connecting with other platforms. You remember the joint actions, for instance, which is an important thing, and also to share the experience that has been capitalized in important projects like Young50, and also with the other European networks, with all the European networks that are doing actually every day a fantastic job at national and international level to bridge and disseminating information on good practices and innovations that are produced in our in the various countries and in our European Union. We now move to our last expert. So the hardest part is for you, trying to say something new after what they have said. So please, the floor is yours, Corner Radu, from the European Network for Smoking Prevention. It's not working?
I think it's very easy to say something new, which is not at all new. Tobacco, tobacco, and again tobacco. Because today, tobacco was around, was in the room, but not really mentioned. And I'm very happy that I was invited here today at the end, okay, in this stage of this project. And for me, the fact that we are here today together, it's already a big success of the project. So I will start from what Michele said about awareness. And you mentioned also that in the analysis of the CARDIO50 project in Italy, you saw a success rate of 16% in terms of decrease of tobacco consumption, which is fantastic. It's not very easy to have such success rates in decreasing tobacco consumption because, you know, it's a high level addiction. Okay, short time, but you said that maybe it's not so high, but it's very good. And just to tell you, Elizabeth is a former president of the European Network for Smoking and Tobacco Prevention. And we have also in the room the current president, Professor Mihalțan from Romania. So here we see and we saw during the screening the effects of tobacco consumption. So maybe from the tobacco consumption or tobacco control perspective, 50 it's a little bit late, but we can use the data in our activity, as you mentioned, to disseminate the data, to show the effects, and to use the results in prevention more. And also speaking about the 17 years, we saw today a very nice graph. ENSP started in 1997 under the Europe Against Cancer program. Today, after 25 years, we have a beating cancer plan. So again, at the Euro level, we are discussing about cancer. So it's okay. We are somehow back. And in terms of tobacco control, in the meantime, we succeeded to have the only public health international treaty, the Framework Convention on Tobacco Control, which is ratified by almost all countries in this world, except the countries that are not ratifying international treaties. But even in these conditions, we have new products on the market, which are not yet regulated. So the industry is not sleeping. So we see big results, big achievements in the past 25 years, but somehow we are again at the beginning. A new cancer, beating cancer plan, new products on the market, not covered by the international treaties or by the European directives. So what we can learn from this? I think we always must look ahead and to start to be predictive, not reactive, because what we are doing mainly is to react to the problems. Maybe it's time to predict the problems. And this is my last word. Thank you.
And thanks a lot. So this is for all of you, actually. Thanks a lot for your last message on the fact that we should start to be predictive, not just look back. Most of the times we are always back from the beginning, and we have these kind of feelings that we do not move forward. But we need to start from to change perspective and be predictive. I agree with you. So thanks. Also, Jacqueline, I see that you are still there. So thanks for staying. I thank you all the experts for your very important messages and for your very important suggestions. You don't know, but it's not over yet for you, actually, because in the coming days, we will send you a brief summary of the things that you have stated, and also a brief summary of the things that we have learned from the day, okay, all together. And we will ask for a validation from you on the statement that we will make. I don't know if there are questions from the audience. Yes, we have already one question for the, I don't know if it's for the experts, I guess so.
Thank you. My name is Lucia Lotrian. I'm from a non-governmental organization, IRPU Romania, which is implementing the Young50 project in Romania. The Young50 project, as the name is saying, is addressing assessing of cardiovascular risk factors among people around the age of 50. And in different countries, we had the problem mentioned before of recruitment and convincing people who still believe they are young and healthy and strong to come to our screening program. And I would like to ask a question to Professor Paul Dendale. You mentioned the importance of new tools, genetic tests, in order to have a better assessment. In terms of recruitment and convincing people to come, which age would you think would be appropriate to include such genetic testings besides the others approaches? And what do you think, including this kind of tests, will increase the acceptance rate, the participation rate in terms of screening, but also in terms of acceptance of healthy lifestyle recommendations or even medical treatment?
Thank you for the question. I think at the ESC, we are mainly interested in lifelong prevention. And I sometimes say we should start before birth or even before conception and end after that. And then we have the whole spectrum. It can already have an impact if young people want to get a child, then they sometimes are in contact with a medical people. There, it's important already to stress that if a father smokes before he conceives of a child, the child will have a higher risk of cardiovascular disease. The same during pregnancy. If the mother is obese during pregnancy or gets diabetes or hypertension, again, an increased problem. And so I think in each stage of life, we can have some kind of screening. At school, there is some school screening in most countries. When you're pregnant, you're followed by a gynecologist. He should look to more than only the growth of the fetus, but also at your blood pressure, and think about the fact that if you develop diabetes during pregnancy, a large part of these women within a few years are diabetics. So that's already an early kind of screening. The same with people starting to work somewhere, or they often there is also medical screening at the start or during their stay. And then, of course, the more you grow older, then of course people come into contact with the doctors because they have some kind of health problems. And I think genetics is gonna change things, but it's not gonna take all the work out of our hands. I think if you have, my idea is in the near future, we will have a genetic passport at birth so that you already know where your let's say weaknesses are. And so then of course it's again a question of convincing people that they should try to avoid these weaknesses. Because if a patient has a family history of coronary artery disease, it's logical he shouldn't or she shouldn't smoke. But not everybody listens to these good advices. But I'm convinced, as I said in the beginning, small effects in large number of patients will have a large health impact. So don't be unhappy about the fact that only 16% of people stop smoking. Even only 5% of people stopping smoking in the whole of Europe will make a major impact. And the same for people moving slightly more, even let's say walk 1,000 steps more, but for 500 million people will make a difference.
Yeah.
So my view is lifelong prevention. Use any contact there is. So there is no extra need for a program specifically for these people because there are so many medical contacts already. Use these as a way to do screening and eventually intervention.
Yeah, the message is don't give up. Okay. Jacqueline, I see your hand raised. So if you want to,
Yes.
yeah, take the floor.
I do want to add to that because it's actually a discussion that we're thinking about clearly from an obesity perspective. And one of the things which keeps cropping up is about creating a win-win situation. So why would somebody want to go and get screened, in our case, for obesity and or for cardiovascular and all of these things? So particularly when you've got a lot of, shall we say, privacy issues and GDPR attached to it. So what we're thinking about is, well, you know, in purely pragmatic terms, think about it. Would you go and get screened if you thought that you'd be able to manage your health more generally better? Would you go and get screened or be happy to have an automatic opt-out screening at national level? If you thought that, actually, someone's going to be monitoring my data so that they'll pick up if there's something going wrong a lot faster, or if my medical insurance premiums are going to go down, all these sorts of things. So at the moment, we're actually working on the question of why would citizens, because when you're in prevention, it's a bit late once you're actually a patient, why would citizens want to actually hand over their data, in our case, for secondary use of data? Simple answer is because it's going to be interesting for them for primary use, so all of that clinical co-decision making. And I think that if we, within the health professional and data gathering community, took those realities on board, we could actually then form really impactful and creative marketing to, in effect, just like supermarkets do, what's in it for the end user. And I think we'll find that different people have different types of incentives, but a lot of us will say, if I have complete data, I'm a lot more likely to actually keep up and follow, because I suddenly have a vested interest in my data and in my health and how I compare to other people.
Thanks a lot again for your very pragmatic message as before and approach. Today, I've learned that we need to be pragmatic and we need to be predictive as well as an approach. I don't know if there are any other comments or questions from the audience. We are very, very late, I guess. Elizabeth, you're saying yes? No. We can go on with the second question if you want. But I don't know, maybe another mission for you, closing the event.
Thank you very much. Actually, we are not late. We were late, but the closing time was 1800, 6 p.m. So it's still 4 minutes.
Yeah, perfect.
So if there are no questions, I thank everyone for their participation, especially our final roundtable. I think it was really very interesting and lots of inputs for us. And I'm very happy to say, Paul, that actually our region have a program. It's our regional prevention program. And we also say from zero, like from the mom's uterus, like right from the mom's belly to 110, I always say, in health, in good health, we need to do prevention and health promotion. And certainly we will keep in mind also what you said. We are actually trying to not invent anything new, use what we already have, and not only use, because we need to reinforce actually, because unfortunately COVID has taught us that it has really reduced our workforces and also our motivation in a certain ways, because it has hit us so hard. And a lot of people are changing, places, workforces are going and stuff like that. So we need to reinforce these, especially in prevention, and we'll try to do that. So I'm very glad that we are in line with what also the WHO said, because we are keeping in mind, tobacco control has always been my passion, as you know, Cornell. And now it's actually also, it's gone to active movement, physical exercise, healthy nutrition, because I'm actually working at the moment in the nutrition department, still in the prevention department. And so we are all there, and I hope we will be able to carry on the good, whatever we've learned and manage to transfer it to other people without waiting it to be 17 years, hopefully. And thank you really very, very much. And thank you also, Giovanni, for the roundtable. And thanks again to Joanne, because she's our project manager. She's there. A big clap to you. Yeah. And thank you very much to Carlo. He's also our team worker, and he's the head of innovation and development unit in our local health authority. And thank you very much to Dr. Sbrajo, who is also here. He's the head of department of prevention in our local health authority. and all to all our partners and the participants. And thank you very much also to ProMIS, who organized also this event for us here, and to Federico and Francesca, who is not here. Anyway, thank you very much. So thanks to all, and actually our guests are invited if you would like to join us for dinner tonight. We are very happy to take you out to dinner, and it will be my pleasure to offer it to you. Thank you very much. I'm sorry, Jacqueline, that you are not here, but it will be for the next time. Thank you very much.
Thank you, Lisbeth.
You will. Thank you.